أنا اسمي دكتورة ولاء خيري. أنا أستاذ مساعد بقسم الصحة العامة كلية طب جامعة القاهرة. إن شاء الله أتشرف إن أنا أكون مع حضراتكم النهاردة بإذن الله. نبدأ بالintroduction to disaster management. لو حد من حضراتكم عنده أي استفسار أو أي سؤال ممكن يبعت على الشات، وأنا هشوف المسج بتاعه بإذن الله وأرد على استفسار. طيب نبدأ النهاردة في نهاية المحاضرة بتاعتنا. What is the intended learning objectives for our lecture? By the end of this lecture, you should be able to define types and levels of disasters. لازم نعرف إيه هي الأنواع والليفلز المختلفة للديزاستر. Recognize disaster consequences, interpret the meaning of vulnerability, and categorize steps in the disaster management cycle. طيب what is a disaster؟ يعني إيه disaster؟ يعني إيه كارثة؟ يعني إيه major incident؟ في الحقيقة في تعريفات كتير للديزاستر. there is more than one definition for the disaster. اللي احنا حاطينهم هنا في المحاضرة بتاعتنا هي الموست basic definition. اوكي. Disaster is sudden and serious disruption of life and may be death or injury to large numbers of people. الديزاستر ده حدث أهم ما يتميز به إن هو مفاجئ خطير ممكن يؤدي إلى توقف الحياة. مش بس كده، ده ممكن يؤدي up to death أو injury to large number of people. There is more than one classification for disaster. The most popular classification is whether the disaster is man-made or natural event. يعني احنا بنبقى عايزين نعرف هل الديزاستر ده هي من صنع البشر ولا natural without any interference of man. طيب ايه تاني من ضمن تعريفات الديزاستر او definition of disaster؟ إن ال disaster is a situation resulting from an environmental phenomenon or armed conflict. يعني ممكن تظهر الديزاستر نتيجة مشكلة بيئية، فولكان ظهر، فيضان، جفاف، or armed conflict، صراع عسكري that produces stress, personal injury, physical damage, and economic disruption of great magnitude. يعني الديزاستر ده هي عبارة عن حدث بيحدث نتيجة ظاهرة بيئية أو صراع عسكري ينتج عنه ستريس، ينتج عنه إصابات، ينتج عنه physical damage، وينتج عنه كمان تأثير اقتصادي كبير الحجم. Disaster happens when the damage caused by an event becomes so great. هي في شرط مهم جدا للديزاستر، ان الديزاستر بالذات عشان اقدر اقول ان دي ديزاستر او دي major incident لازم يكون اللوكال mechanisms for response become overwhelmed. الريسبونس الطبيعي اللي بينشأ لأي حدث يكون overwhelmed بالحدث ده. and outside assistance is required. يعني أنا محتاجة مساعدة خارجية to cope with this damage. طيب what is a major incident؟ A major incident is any incident that its location, number, severity or types of casualties requires extraordinary resources. هو حدث مكانه، عدد الإصابات، نوعية الإصابات، درجة الإصابات تتطلب extraordinary resources. يعني ايه extraordinary resources؟ زي ما قلنا ان اللوكال ريسبونس مش قادر يتعامل معاها، النورمال ريسبونس مش قادر يتعامل معاها، يبقى احنا محتاجين في هذه الحالة extraordinary resources. طيب الكلاسيفيكيشنز بتاعت disaster. The first classification is whether the disaster is natural or man-made or hybrid. What is a natural disaster؟ هي disaster بدون أي تدخل من الإنسان. زي إيه؟ زي الإيرثكويكس، الفلودز، الهurricane، التسونامي، كل دول مفهومش there is no any type of human intervention or human cause. Okay. Number 2 is man-made. Man-made, the main examples for man-made disaster are nuclear incidents and industrial accidents, or hybrid. Hybrid as spread of communicable disease. The nature has a role and also the man has a role. Okay. For example, the COVID-19 pandemic, both nature and man has roles in spreading the pandemic. Okay. So natural as earthquakes, floods, hurricane, man-made transport accidents, which is one of the most commonest man-made major incidents, and industrial incidents. Industrial incidents meaning an accident in a factory, in a nuclear station. Hybrid, as in case of spread of communicable disease, the nature has a role and the man has a role, as in case of outbreaks, global warming phenomena. Another classification is simple versus compound incidents. Here we must ask ourselves a very important question. The question is the infrastructure intact or has been damaged؟ هل البنية التحتية سليمة ولا البنية التحتية تدمرت وتأثرت بهذه الديزاستر؟ لو البنية التحتية سليمة it is a simple instance. لو البنية التحتية تم تدميرها it is a compound instance. So a simple incident in case that the infrastructure remains intact, while the compound incident is when the infrastructure is damaged. No roads, no hospitals, no lines of communication, for example, no electricity, no water. Okay. The third classification is compensated versus non-compensated incidents. A compensated incident, here the load is less than the capacity, while the uncompensated incidents, the load exceeds the capacity. What is the meaning of load is less than the capacity? In few days, in few hours, I can manage the disaster, okay, with the extraordinary resources, but the uncompensated incidents, I cannot manage the disaster even in the presence of the extraordinary resources. بمنتهى البساطة compensated incidents أنا قدرت أعمل management للديزاستر لأن اللود كان أقل من الكاباسيتي، لكن ال uncompensated incident here هنا اللود أكبر بكتير من الكاباسيتي بالرغم من وجود extraordinary resources، موارد خارجية جات لي، مساعدات خارجية، أنا برضو still مش قادر أمانج الديزاستر. طيب ايه اكبر مثال للuncompensated incident زي اللي حصل في المرفأ بتاع بيروت؟ لو حضراتكم تفتكروا الانفجار بتاع مرفأ بيروت، قعدوا ايام طويلة بيحاولوا يخرجوا الضحايا ومش عارفين يخرجوهم تمام، بالرغم ان كانت لهم مساعدات مش بس extraordinary resources، ده كانت لهم international assistance، يعني جالهم مساعدات خارجية ودولية. What are the levels of disaster? There are more than one level for disaster. Level 1. What is level 1 for disaster? A level 1 disaster is a single or multiple country event. The event is targeting one country or more than one country, but there is minimal public health consequences. The public health consequences are very minimum. Okay? Localized emergencies as small-scale fire, landslides, low-level epidemics are usually taken care at the district level. الليفل الأولاني هنا بيأثر بمينيمال public health consequences على دولة أو أكتر من دولة. هنا المانجمنت بيتم على مستوى الديستريكت ليفل، بيتم على مستوى الإدارة، يعني بسمول intervention بlocalized emergency I can manage the event. Level 2 of disaster, it is single or multiple country event, but in this case there is moderate public health consequences, which requires a moderate country response or a moderate national or international or regional WHO response. هنا local community resources، الريسورسز الموارد اللي داخل دولة لوحدها مش قادرة على استيعاب، مش قادرة على التعامل مع الحدث، لكن هنا يتطلب moderate country response or moderate international WHO response. The World Health Organization must intervene in this case. What about level 3? Level 3 is a massive disaster, massive situation, very, very critical situation. It has severe public health consequences and requires a very, very large international response. Here, there is massive level of damage. Here, in this case, the country or the multiple countries require international assistance. I think most of you remember the COVID-19 pandemic, where many countries required international assistance, requires massive and large assistance from other countries to bridge this event. Okay? يبقى level 3 ده أعلى level من درجات الديزاستر، massive disaster، بيؤثر تأثير قوي جدا جدا على ال public health consequences and requires an international response. These are the 3 levels of disaster. What are the disaster consequences? The severest disaster consequences is, for example, deaths, injuries, illness, disabilities, also the psychological effects and the post-disaster traumatic effect. All these health effects can be directly or indirectly. How it is directly? There are deaths or injuries or casualties due to the effect of the disaster. And how can it be indirectly? Most of disasters is linked with disruption of health system and services. As for example, in case of wars leads to disruption of health system and services. You go seeking medical care or medical service, but you cannot find it. Okay? In disaster, people have reduced access to healthcare. They cannot access healthcare. For example, due to geographic reasons or due to unavailability of the services. Disaster also affects the basic supplies and infrastructures such as the food, the water, the sanitation, the shelters, and all of these supplies and infrastructure, and any impact on them leads to severe health consequences. What is a humanitarian crisis or emergency? How can we define a humanitarian crisis? Humanitarian crisis, there is no or humanitarian emergency or humanitarian disaster, but we can define it as a event or series of events that represent a critical threat. It has a critical threat, very critical effects on health, safety, security, well-being of a community or large group of people over a wide area. In this case, we have a humanitarian crisis. You can use the term humanitarian crisis or humanitarian emergency or humanitarian disaster. All of these terms are alternative to humanitarian crisis. Okay. What is a complex emergency? A complex emergency is a humanitarian crisis in nature. It occurs in a country or a region or a society where there is total or considerable breakdown of authority. In the complex emergency, the authority in this country has broke down, okay? This may result from course requires an international response that goes beyond the mandate or capacity of any single agency. And it requires also intensive and extensive political and management coordination. A good example for complex emergency is as in the case of wars. Wars is considered a complex emergency, as it may lead to the breakdown of the authority. The conflict may be internal or external. It, of course, requires extensive political and management coordination. What is the characteristics of complex emergency? One of the most important characteristics is the displacement of the population. As you can see in the picture, massive population movement. The people move from their houses, their villages, their towns to other more safe areas. Here is a list of the characteristics of a complex emergency. One of the most important characteristics is the displaced population. Also, extensive violence and loss of life. Complex emergency leads to violence. Violence against children, against women, against the elderly, and may lead up to loss of life and death. Also, widespread damage to the societies and the economies. Their houses, their work, their shops, their building may be damaged. A need for large-scale, multifaceted humanitarian assistance. Here, the assistance and the efforts and the response must be at large scale. In a complex emergency, there may be prevention of humanitarian assistance by political and military constraints. Also, workers or humanitarian workers who goes, for example, at the wars or the countries where there is conflict, they are subjected to security risks. They may be exposed to very, very critical risks. Okay, what is the direct and indirect impact of humanitarian crisis? According to the type of crisis, we can classify the impact into direct impact and indirect impacts. The direct impact is in case of natural disaster, as earthquake, volcano, droughts, the infrastructure may damage. You remember the earthquake that happened in Morocco, الزلزال اللي حصل في المغرب. Houses, roads, bridges, health facilities, schools were affected. Mortality and morbidity increase. Mortality in terms of deaths and morbidity in terms of diseases. Also, there may be agriculture loss. There may be affection of the cultivated land. What is the indirect impact of natural disaster? One of the most indirect impact of the natural disaster is the stunted economic growth. It will affect the economic growth. It can weaken the health system by affecting the supply chain interruptions and lack of human resources. What about man-made crisis or conflict? What are the direct and indirect impact, health impact in this case? The direct impacts are like disease, human rights abuse, children are abused, women are abused, psychological disorders, psychological traumas, injuries, casualties. Also, direct attack on health workers. Unfortunately, health workers may be attacked during conflicts. Forcible displacement of non-health professionals, displacement of populations. The people has to leave their homes to go to more safe areas. Barriers to care. They cannot access health services. Also, ambulance and service vehicles cannot reach the patients or the injured. What are the indirect impact of man-made crisis is conflict. One of the most important indirect impact is displacement, infrastructure destruction, their homes, their buildings, everything is damaged. Lack of food, they don't have food. Environmental and healthcare degradation, the health services are disrupted. Reproductive health problems among people living in the crisis, malnutrition, intimate partner violence, violence between the wife and husband, diarrheal diseases, especially among children, rendering or preventing implementation of humanitarian interventions. All of these are indirect impact of man-made crisis. What are the direct and indirect impact of complex emergencies? Complex emergencies is very similar to conflicts or man-made crisis. There will be population displacement. People leave their homes and may go to other countries to find more safer places. Excess mortality and morbidity. Diseases are more, injured are more, and poor security. They don't find security. They are insecure. What about the indirect impacts? One of the important indirect impacts is the transmission of communicable diseases or food shortages, which can lead to increase in the mortality and morbidities. The economic instability, there is no money, there is no economic instability. The people are not working, Okay, so the economy doesn't grow anymore. Weakened health system, especially if already the health system is fragmented or weak. Logistical challenges, many logistical challenges happen in this case. What is the concept in evaluating disaster? The concept in evaluating disaster, you have to consider three very important items. Number one, the phenomenon, the type of disaster and its intensity or magnitude. A disaster, its scale is 7 Richter, is different than a disaster, an earthquake with magnitude of, for example, 2 Richter. Okay. The type of disaster, is it a conflict? Is it man-made? Is it natural? The vulnerability of the population. Is your population have vulnerable groups? For example, the vulnerable groups are elderly, children, women, okay, mentally ill persons. The capacity of the local response, how can your health system and other sector respond to the disaster? Are they strong enough to respond? And lastly, the impact. What is the impact of the disaster? What is its effect on the population? Vulnerability. What is a vulnerable population? A vulnerable population, someone who has difficulty communicating, he cannot communicate, has difficulty in accessing medical care, he cannot access medical care, he needs help, may need help maintaining independence. He cannot be independent, as for example, children or geriatrics. Requires constant supervision. He needs supervision, as for example, mentally ill patients. May need help accessing transportation. He cannot move from one place to another alone. He needs someone to help him, as for example, patient with physical disabilities. What is the impact on health in case of communicable disease? There are two possible scenarios. What are these possible scenarios? Number A is the risk of outbreak associated to other events and emergency, or an emergency caused by an infectious disease. Risk of outbreak associated to other events and emergency, as for example, outbreaks of cholera during the Yemen war. Okay, emergency caused by infectious disease, as for example, H1N1 pandemic, or SARS pandemic, or COVID-19 pandemic. What are the factors that affect the spread of communicable disease during disaster? One of the most important factors is this population can access health care or not. For example, if there is health services collapse, if there is lack of disease control program, if there is poor access to health care, is there interruption of the health services or not? Population characteristics. Also, the population characteristics is very important. Is this population displaced or not? What about the size of the population? Is this population immune against disease, especially children, for fear of spreading of infectious disease or communicable disease as polio, pertussis, diphtheria? Are these children immune? Did they take this vaccination or not? Okay. Also, the environment has a role. Is there safe water supply? Is there sanitation, proper sanitation? Is this there is access to food. And when we talk about food, we talk about food in terms of food quantity, food quality, and food security. Also, what is the health risk due to communicable disease? Due to communicable disease, there will be increased morbidity and mortality. For example, waterborne disease. One of the most common water and foodborne pathogens during disasters is cholera, typhoid fever, shigellosis, hepatitis A, hepatitis E. Also, there is fear of vector-borne diseases. For example, malaria, dengue fever, yellow fever, Rift Valley fever. Also, overcrowding related disease. There is diseases that result from overcrowdedness, and overcrowdedness is very common during disasters. Measles, meningococcal infection, tuberculosis, diarrheal diseases. Also, if the children didn't take their vaccines, there will be vaccine preventable diseases. And this is what we call a missed opportunity to prevent these diseases, as measles, polio, tetanus, pertussis, diphtheria. Also, the impact on health in terms of spread of non-communicable disease. Non-communicable disease is linked to the supply of medication and the availability of treatment and health services. If during the disaster, the medication and supplies are interrupted or stopped, or the healthcare facility is damaged, this would lead to exacerbation of a lot of non-communicable disease, as for example, cardiovascular diseases, diabetes, cancer, chronic respiratory diseases, blood disorder, renal disease. Or due to inadequate case management, the patient went to the clinic or went to the health facility, but there was inappropriate or insufficient case management. For example, in the USA in 2005, the Orleans hurricane had displaced local population. 68% of medication dispensed in one evacuation center were for treatment of non-communicable diseases. What is the impact on health in terms of water, sanitation, and hygiene? The term WASH refers to the provision of safe water for drinking, washing, and domestic activities. Also, safe removal of waste, and finally, health promotion. So, WASH must be applied during disasters. Hazards can affect the availability of safe water supply and waste management infrastructures. In case of impact on water, sanitation, and hygiene, there will be increased risk of infection. The risk of infection will increase due to consumption of contaminated water. The water is not safe. Consumption of food, the food is insecure. Hand-to-mouth transmission because they don't have cleaning facilities. Vectors because there will be breeding near waste sites and stagnant water. In addition to exposure to medical waste, if this population are exposed to medical waste, like supplies or equipments with medical waste, blood discharges, okay, it will lead to increased risk of infection. Also, the health risk increase in terms of diarrheal diseases, water, sanitation, and hygiene are very linked to foodborne infection. The most common foodborne infections are diarrheal diseases, hepatitis, cholera, typhoid, Shigella, hepatitis B and hepatitis C and HIV, and these are blood-borne pathogens in case of hospital waste. For example, in 2004 in Haiti, the earthquake and the hurricane have damaged the country infrastructure. Access to safe water and adequate sanitation was completely destroyed. In this situation, the cholera did spread very rapidly. Cholera is closely related to unsafe water supply or contaminated water supply with sewage. Impact on health in terms of nutrition. In terms of nutrition, disaster exacerbates malnutrition. Vulnerable populations are the most exposed populations to malnutrition, or infants, young children, pregnant and lactating women, and elderly. Malnutrition severely affects these population segments. Also, health risk include health risk related or linked nutrition may include malnutrition, and in this case, it will be severe acute malnutrition due to the situation and inadequate food supply. Stunting, the children will suffer from stunted growth. Micronutrient malnutrition in terms of iron deficiency, vitamin A deficiency, zinc deficiency, and other micronutrient deficiencies. And also, في صوت. And on the long term, early malnutrition, if the disaster continues for a long period, for example, years, months, okay? The disaster, the early malnutrition will predispose to overweight, obesity, chronic diseases. For example, in Indonesia, in 2006, what happened? Following the earthquake, the poorly regulated breast milk substitute were provided to babies who didn't feed on breast milk and take artificial milk. They suffered from increased incidence of diarrhea among these infants. What is the impact of disaster on reproductive health? Reproductive health can be greatly affected with disasters. The health risk especially affect adolescents because they are more vulnerable. Family planning methods must be secured during disaster. Any shortage in family planning will lead to unplanned pregnancies, and the people or the women will be willing to do abortion, so this will increase the risk of unsafe abortion. So shortage of family planning methods during disaster is very, very critical. Okay. Also, it can affect the health of the mother and her newborn. It can increase the risk of maternal and neonatal mortality. If the pregnant woman doesn't find a safe place to deliver her baby, she will be subjected to death, and also her baby. Also, there will be increased risk of sexually transmitted infection. For example, HIV/AIDS. Does the disaster affect the child health? The disaster is one of the most important groups directly and indirectly affected by the disaster is the child health. The children are exposed to communicable diseases, especially if they didn't take their vaccines. They are exposed to malnutrition due to shortage in food supply. They are exposed to injuries and casualties, And also they can be separated from their parents, especially if one of the parents died during the disaster. Does the disaster has an effect on mental health? Yes, disaster has a great impact on mental health. During disasters, there are extreme stress. Also, people with pre-existing mental disorders, if a person was suffering from a mental disorder before the disaster, he may not be able to find services to take care of him. He might not find mental health services because all the health services will be allocated and directed to the management of the injured and the casualties resulting from the disaster. The social and psychological health risks will include exacerbations of pre-existing condition as well as disorders resulting from the emergencies. What is the impact of disaster on the mass casualty? Mass casualties following disaster are often characterized by quantity, severity, and diversity of injuries. Mass casualty means the injuries, الإصابات، المصابين، تمام؟ المتضررين. How can we measure this impact? We can measure it in terms of quantity, severity, and the diversity of injuries. What are the types or the common types of injuries during disaster? One of the common types of injuries is blunt traumas, crush-related injuries، يعني خبطات، انفجارات، drowning، غرق، mental health issues، حاجات تؤثر على النفسية. Most people don't die and may have long-term consequences. Most of the casualties resulting from disaster result into long-term consequences. It may result in disabilities. Amputation of one of the limbs is a common example during disaster. Also, what is related to mass casualties is injuries, increased mortalities, handicapping and disabilities, severe traumas and wounds, maternal and newborn emergencies are very common. How can you manage mass casualties during disaster? You need early intervention. Early and timely intervention and management is very, very critical. In this case, there are two levels for operation. On-site operation at the site of the disaster, okay, at the scene of the disaster, and at the hospital when the patients are transmitted from the site of the disaster to the hospital. Okay, for example, during the Haiti earthquake in 2010, it caused more than 300,000 non-fatal casualties. Okay. What is the impact of disaster on mass fatality? What is the meaning of fatality? Fatality means أموات. Okay. موت أو خطورة. Okay. Fatality means dangerous and severe impact on health up to death. What is the health risks in this case? Fatality leads to distress of families and community. Okay. Fatalities also increase the risk of infection due to consumption of water that may be contaminated with feces of deceased person. Risk of secondary contamination from fatality if the one who died are exposed to chemical or radiological agents. It may continue to affect the surviving individuals or the survivors from the disaster. Okay. Concept in evaluating disaster is phenomena, which means the disaster magnitude or the type of disaster multiply vulnerability, the vulnerable groups in your population, and the capacity of your system to meet this vulnerability will end result in the impact of the disaster. What are the sectors involved in disaster management? There are two main sectors involved in disaster management. The first most important sector is the health sector, okay? Are there other sectors involved in disaster management? Yes, there are other sectors may be greatly involved, as the defense sector, as the police sector, as the environmental sector, as the agriculture sector, as the food supply, as the sanitation sector is involved in food supply, sanitation, waste management, water supply. All of these sectors plays a very important role in disaster management. We will start with the health sector. What is the role of health sector during the disaster management? The health sector provides more than one type of services during the disaster. One of the most important services delivered by the health sector is the ambulance services. What is the ambulance services? الخدمات الإسعافية. The first crew who reach the scene has special duties. In every ambulance vehicle that reach the scene, there are two persons. One is called the assistant and the other is called the attendant. The assistant who drives the vehicle, the assistant should stay within the vehicle and maintain communication with the emergency control, while the attendant must deliver the first situation report to confirm that there is a disaster in this place. The first ambulance at the scene will forward the other ambulance services. There is a very important rule that under no circumstances should this group become involved in patient treatment. The first ambulance crew should not be involved in treatment of patient until they deliver the situation report. Why? To not waste time with patients and hindering or being late to forward the other ambulance services. These are the responsibilities for the first crew on the scene. The assistant parks as near as possible to the scene, maintain communication with the attendant, and stay within the vehicle, while the attendant should declare major incidents, gives the situation report, and decides needs for medical team. Also, he can set up key areas as control point, parking point, casualty clearing station. What is the responsibility of the other ambulance services personnel when they reach the site or the scene of the disaster? They should start saving life, preventing further injuries, relieve suffering, determining the receiving hospitals, determining priorities for treatment and evacuation, arrange means of transporting the injured. They have to save as much lives as possible, relieve the suffering, and do the triage, perform sorting of cases. Okay? The second type of services provided by the health sector is the medical services at the scene. What is the role of medical services and on the scene, and when they have to be called? When do the ambulance services is not enough and you have to call medical services, you need expert clinicians or specialists. When? Okay, this is done when the ambulance services alone cannot manage. In this case, you will need expert clinician to perform triage. For example, they could perform management of airways and life-threatening condition. They could perform local and general anesthesia. They could perform surgical procedures up to amputation. The third type of services is the support services. What is the support services? The support services are agencies requested to provide assistance at the scene, but they must be not part of the health or the emergency services. What is the most famous or the most common support services during the disaster? One of the most common support services during the disaster is the volunteers. Who are the volunteers? These are people who provide support, provide empathy, provide help, okay, without being part of the medical team or the ambulance team. One of the most important assistants to the emergency services is the local authorities. And they play a very, very important role during the recovery of community. For example, when an earthquake happens, a building collapse, or remove the impact of the damage of the infrastructure, this is the local authority. The local authority is, for example, المحليات الإدارات المحلية للتعامل مع الأزمات. What is the highest support services during disasters? The highest support services is the military. And the military is called especially when the incident is compound, as for example, to build bridges or shelters. What is the personal equipment needed during disaster management? There are multiple personal equipments needed during emergency, and these personal equipment should fulfill the following: personal safety, function and durability, and comfort. I have here a comment. Someone is saying we have to have emergency plan A, B, C, plan A, direct and indirect management, plan B, backup plan, okay, plan C, ultimate chains of backup plans. Of course, we have to do so, and we will discuss this in details during the hospital emergency management in the next lectures. Okay, thank you very much for your comment. Okay. How can you fulfill the personal safety in the personal protective equipments? This can be done by protecting vulnerable body area. And what is the vulnerable body area? Vulnerable body area is according to the exposed part and according to the type of the disaster. For example, if we are talking about earthquake, the head may be affected, the body may be affected. But if we are talking about, for example, car crash or accident or radiological explosion or chemical explosion, there will be different vulnerable body areas. Okay. These are examples for some personal protective equipments used during the disaster. Also, the personal protective equipment should be visible and should be identified. There should be a label in the front and back for your identification. Either you are press, you are health services, you are police, okay? And it should fulfill warmth and waterproofing. The equipment storage should be stored under the suitable storage conditions, as well as you must know if your personal protective equipment is durable or not durable. What about the medical equipment? The medical equipment that you will use will differ according to the level of medical intervention that you will apply during the disaster. There are 5 levels of medical intervention. The most basic level of intervention is triage. What is the meaning of triage? Is the equipment used to sort cases according to the priority of their treatment. Number 2 is life-saving first aid. First aid that requires very simple equipment. Then there is advanced life support, more complicated equipments, specialist medical equipments. If you need equipments, for example, operations, for anesthesia. And finally, the packing for transport, how you will pack patients or injured persons for their transport. These are examples for medical equipment used during disaster management. And these are examples for additional equipments that are used for advanced life support. Specialist medical equipments. The specialist medical equipments are especially needed, okay, for mobile medical teams, for advanced procedures that the paramedics cannot perform it. Okay, example for specialist medical equipment is amputation cysts, also advanced drugs used for general and local anesthesia. Packing for transport. How can you transport the patient, or how will you transport the patient from the scene to the hospital? They should be properly packed, okay? And these are examples for equipments used for packing the patients. Okay, what is the role of the other sector during disaster management? The role of other sectors is mainly in supplying food supply, storage, and safety. Number 2 is safe water supply. Number 3 is waste management. Any of these 3 items is affecting during the disaster may lead to severe health consequences that may be more than the effect of the disaster itself. For example, if there is no safe water supply or no sanitary waste management, there may be outbreaks of cholera, and cholera is very fatal, okay? So we will start with food supply, storage, and safety. The food in disaster may be very scarce. Scarce means limited. Also, the available food may be contaminated. So there might be lack of suitable conditions for preparing food with poor sanitation. In addition to, there may be inadequate safe water supply. All of these are very important challenges for food supply storage and safety during disaster management. What are the most important strategies that are used to ensure food safety, supply, and storage? These strategies are mainly addressing the following. The strategies are addressing food safety measures, safe food handling, safe and hygienic warehouse management, assessing pre-packed food, assessing refrigerated food, and finally, the food delivery. We will start with the food safety measures. The WHO has mentioned or has stated 5 keys for safer foods. What are the 5 keys for safer food? The 5 keys for safer food, number 1 is keep clean. Use clean food, clean materials. Okay. Number 2, separate raw and cooked food to avoid transmission of infections from raw to cooked food. Number 3, cook thoroughly. You must ensure that the food is properly cooked. Number 4 is keeping food at safe temperature by putting it in a refrigerator and monitoring the temperature of these refrigerators. Use safe water and raw materials. The water and raw materials that you use during food preparation must be safe for human consumption. Okay? How can you ensure safe food handling? Number 1, you must ensure that the food you are using and the mass feeding programs that may provide food, that this food must be fit for human consumption. Also, if feasible, stocks are regularly inspected and samples are sent to special labs for analysis and being sure that it fit human consumption. Kitchen supervisors, the cooks should be taught about personal hygiene, should be given health education about safe food handling, and volunteers should be advised and asked not to stop food handling, and they can help in other services if anyone is suffering from jaundice, diarrhea, vomiting, fever, sore throat, skin lesion, ear, eye, or nose discharge. Safe food handling also involves adequate facilities for waste disposal. Minimum is cleaning hands and washing hands with water and soap. How can you ensure safe and hygienic warehouse management? The place where you store the food, how can you ensure that is safe? First of all, there should be good roofs and ventilation. The products must be kept away from walls and off the floor. Plastic bag should be placed underneath them for protection. Also, the building where the food is stored in it should be sound and healthy and clean. Spilled food should be swept up. Foul and pesticides should never be stored together with food. If you have to do spray operation for pest control, kindly all the stuff and all the stocks should be carried out by qualified technical staff under close observation of the national authority, and then you do your spraying, and after proper ventilation, return everything to its place. How can you assess pre-packed food? Discard canned food with broken seams or leaks. Undamaged canned foods that looks good should be washed before opening to avoid risk of infection. How can you assess the refrigerating food? First of all, you should make sure that the refrigerators are functioning. Okay? If power is not available, try to use refrigerated food, especially meat and milk, as soon as possible. Okay, some foods can normally be stored in the refrigerator more than others. The temperature and the expiry of food differ according to the type of food. Open it only when it is necessary. Open the refrigerator only when it's necessary. Finally, how can you deliver food? What is the delivery system? How can you supply the food to the people who are suffering from disaster? This can be done through two types of efficient and fast mechanisms. The first is mobile canteen and the second is mobile kitchen. The mobile canteen is a truck that is used. It is a truck used to serve food which has been prepared elsewhere, but mobile kitchen is a vehicle occupied to serve but not prepare food. Here I have a comment. Someone says it's better to classify disaster as preventable like industrial related one and non-preventable like earthquake. Yes, it is correct. There are more than one classification for disasters. Actually, there are many classifications of disaster. We use the classification that is suitable for what we need to do with the disaster. Okay, if your aim is to prevent the disaster, so it's okay to use preventable and non-preventable disaster. If your aim is to identify the cause of the disaster, you can use the classification of man-made or natural. If your ultimate goal is to know and act if the infrastructure is damaged or not, so you will use the classification, is the disaster simple or compound. Thank you very much for your comment. It's much appreciated. What about water? What about water? Okay, storage of water. Water is one of the prime requested for living. We cannot live without water. Water is very essential. Essential for drinking, essential for food preparation, essential for cleaning. Okay? So, what are the strategies that we can use for ensuring water supply, purification, and treatment during disaster? First of all, you have to use clean containers, okay, from glass, plastic, metal, okay? You must ensure that there is disinfection of your water containing. Even if you can boil your glass bottles, especially if you will use it for young children less than 1 year. What are the most important methods for water purification and treatment? One of the most important is chemical disinfection. One of the most known chemical disinfection is chlorine. We put chlorine in water for chemical disinfection and killing biological agents. Other type of or strategy for purification and treatment of water is sedimentation. Put the water and leave it to stand. Then the suspended material will settle down. Then you will take the water from the top. Or filtration. Use filter, okay? There are different types of portable filters now is commercially available. Okay, but take care that filtration works only by physically removing the contaminant and doesn't deal with the biological infection. Finally, heat treatment. You can boil the water. Boiling the water will kill organisms, but heat is very, boiling the water is very challenging during disaster because you may have shortage of gas, shortage of fuel. Okay. Waste management. How can you deal with waste management during a disaster? First of all, you will deal with waste management according to the type of the sanitation practice you need to know. For example, defecation, you will use shallow trench latrines, which should be at least 15 meters away from the water source, and the excreta should be covered with at least 25 centimeters of soil. Disposal of corpses and carcasses. How can you, the dead bodies, get rid of it? For human dead bodies, according to cultural and norms and traditions. Okay, you can use burying, you can use burying, you can use incineration. For animals' bodies, you can use one of the following methods: burial, incineration, or composting. What about the sewage and wastewater? You have three options. Number one is discharging the sewage and wastewater into water courses, provided that you don't use these water courses for safe water supply, okay? Or leave it to infiltrate into the soil, or leave it to evaporate. What about the household refuse and solid waste? You can get rid of them either by barrier or sanitary landfill. Sanitary landfill are sites that should be away from settlement or incineration. But take care that ash should be buried and covered with at least 40 centimeters of soil. Okay, any questions, please? Any question? We will move to the next presentation. Please, if any questions on this presentation, please type it on the chat box. Okay. Now I will move to the second presentation. What are the key issues in disaster management? Do you see the presentation? Is the presentation displayed in front of you? Okay. Let's start. Key issues in disaster management. What are the most important key issues in disaster management? What are the cycle of disaster management? What we need to know about disaster management? What we need to learn about disaster management before starting in the hospital emergency management plan? We need to know a very important term called disaster mitigation. What is disaster mitigation? This refers to actions or measures that can either prevent the occurrence of a disaster or reduce the severity of its effect. Mitigation activities include awareness and education, plus also disaster prevention measures. The disaster mitigation main strategy is through hazard identification and also vulnerability analysis. What is a hazard? A hazard is something that leads to a danger, that leads to a harm, that has the potential to harm others. What is the vulnerability analysis? Vulnerability analysis is the analysis of vulnerability in your community. Who are the vulnerable groups in your community? Is there are more old people, or more children, or more women, or more mentally ill, or more people with chronic disease? All of these are vulnerability analysis. البرزنتيشن الأولانية هي اللي ظاهرة. طيب يعني حضرتك مش شايف قدامك الديزيز ميتيجيشن دلوقتي؟ الشاشة مش طالعة؟ طيب أنا هفتح وهقفل وأطلعها تاني وأشيرها تاني. طيب حضراتكم كده هشير تاني السكرين. طيب كده ظاهرة قدام حضراتكم الديزاستر ميتيجيشن ظاهر ولا لأ؟ طيب اوكي كويس كده. طيب خلينا نرجع لورا. ادي disaster mitigation، وقلنا disaster mitigation most important strategy for disaster mitigation is hazard identification and vulnerability analysis. What is hazard identification? Is to identify anything that has the potential to cause harm. Okay? Vulnerability analysis is to analyze and identify the vulnerable groups in your population. Who are the vulnerable groups? For example, elderly, children, infants, pregnant women, people with chronic diseases, mentally ill persons. All of these are vulnerable population. Why we have to identify them? Because the action plans that you will put for disaster management will differ according to the type of vulnerable populations in your community. Okay, disaster mitigation. Disaster mitigation, it is very critical that the health must be one of the center of the whole society efforts. All the society efforts that are done to manage disaster should be most of it addressed toward health. Why towards health? To reduce the vulnerabilities and to reduce the risks and to build resilience. What is the meaning of resilience? To build flexible health system. Flexible health systems that can respond to any type of disaster. This will be done. How will it be done? It will be done through effective disaster prevention, preparedness, response, and recovery, and we will discuss them all in details. This is the disaster management cycle. The cycle, as you can see, is a vicious circle. It begins with mitigation, preparation, response, recovery, and then mitigation. Okay? What are the phases of disaster management? The phases of disaster management, as you can see here, is prevention phase, preparedness phase, response phase, recovery phase. What is the prevention phase? In the prevention phase, you identify community risk factors, then develop and implement programs to prevent disasters from happening. We can use both the terms disaster mitigation or prevention. Okay, they are very close alternative to each other. So you can use disaster mitigation or disaster prevention. Structural mitigation, okay, or non-structural activities. The structural mitigation will reduce the economic and social impacts of the disaster, while the non-structure means that you put policies and practices that raise the awareness of the community to reduce the impact of disaster. For example, building earthquake-resistant buildings. The second phase of disaster management is the preparedness phase. What is the preparedness phase? This phase that addresses personal and professional preparedness. How can you be prepared for a disaster? First of all, you must know the difference between these two terms, vulnerability and manageability. What is the difference between them? Vulnerability is the factors that increase the number of people exposed to the hazard, the area covered by the hazard, the dose or the intensity or power of the hazard, the time duration, and the frequency of the hazard. While manageability, these are factors that reduce the risk by applying coping mechanism to any disaster, increasing the knowledge and the safety practices of the population, the feasibility of the technologies that help the population to manage any disaster. Community preparedness. How can you prepare the community for a disaster? The level of community preparedness depends on the community itself, how the community itself prepares itself to the disaster. For example, does this community have adequate warning system? Does this community have a backup evacuation plan or not? There is something called the emergency operation plan. What is the emergency operation plan? In the emergency operation plan, it allows the community to respond to threats. How? By engaging responders in the short-term recovery. In the short-term recovery from the disaster, you can use a community representative, you can use volunteers. Also, this emergency operation plan should be flexible. The preparedness include preparedness plans, emergency exercises, warning system, emergency communication system, evacuation plans and training, resource inventories, emergency personnel and their contact list, mutual aid agreement between agencies and maybe between countries, public information and education. What are the 6 domains of preparedness? The 6 domains of preparedness, number 1 is incidents management, how you can respond to the incident, information management. You have to have a system for information to respond properly to the disaster, countermeasures and mitigations. Surge management means that you have to expand the medical service to handle large events. For example, if a hospital have health services that normally manage 300 people, and now in this hospital you have 3,000 injured people. How can you do the surge management? By surveillance, by investigating and identifying the health threats, and community resilience, preparing for and recovering from emergencies. The third phase of the disaster management is the response phase. Response phase means that the disaster happened. It varies according to the level of disaster and management plans, according, of course, to the severity and extent and impact of the disaster. An earthquake differs from a volcano, differed from a chemical explosion, differs from a war, okay? What you have to do during the disaster response? You have to implement the existing disaster plans. You have to notify, evacuate, search and rescue, coordinate, immediate needs assessment, shelter and protection. First of all, how can you implement the existing disaster plan? A good emergency plan enables efficient coordination of resources. Very important is the coordination of resources, because the coordination of resources will ensure itself efficient use of resources. The efficiency means that you optimum use of scarce resources, okay? The response actions aimed at this stage to save life, reduce economic loss as much as possible, and decrease the suffering of the people. Also, the response phase includes mobilization of emergency services and responders to the disaster areas. You move and mobilize and reallocate firefighters, police, ambulance crews to go all to the disaster scene. Also activating what is called the Emergency Operations Center, or what we call the command center. We evacuate threatened population from unsafe areas. We open shelters. We provide mass care, and we provide also emergency rescue and medical care. The second item in disaster response is notification. Notification is very, very important. How can you apply notification? You can apply on notification what is called public health surveillance, الترصد. And the surveillance was very much used and common during the COVID-19 pandemic. What is the definition of surveillance? Surveillance is the ongoing systematic collection, collation, analysis, and interpretation of data and dissemination of information. Why? This all must be linked to action. We do surveillance to be linked with action, evidence-based actions. Public health surveillance should be done as soon as possible. We only do it for the principal health outcomes. We limit it to the problems that we can act upon. So if something we cannot do anything for it, so don't collect data for it, as simple as that. Keep the surveillance simple, but also flexible to new health problems. What is the objectives of surveillance in emergency? The main objectives of surveillance during emergency is to detect the outbreaks that requires action. Also, to monitor the health trends, what is decreasing, what is increasing, what is I'm afraid of, what is emerging during the disaster. Is there respiratory infections? Is there food poisoning? Is there cholera? Monitor program performance. Is my program is doing well or not? How can I monitor it? How can I evaluate it? Okay, to modify and put it in the right track. Also, monitor the workload at the health facilities to optimize the allocation of our resources. Also, the public health surveillance during emergency include, you must have a list of disease or events that you are going to collect data about it. You have case definition, and the CDC have made case definition for every single infectious disease. You must have a surveillance network, okay, to facilitate the collecting and reporting the data. You may need lab investigations. You must have analysis and feedback, and then it must be linked to the outbreak response. One of the most important measures is to make the case definitions simple. Don't complicate the case definitions for easily identification by the healthcare provider. As you can see, these are examples for easy case definition. Okay, after you have evacuated and has done search and rescue efforts and coordinated with all other health sector, one of the most important measures done during disaster response is immediate needs response, or what we call rapid needs assessment. What do you do during rapid needs assessment? The rapid needs assessment is done during the disaster, during the response, while the disaster is still happening. What you need to assess during the rapid needs assessment, first of all, is the quality of life of the victims. What is the quality of the life of the victims? What they are suffering from? What is the population affected? What is the access areas? What are the available mode of transportation and the available systems of communication? Is there available services as health services, housing, water, electricity, communication, food? Number 2 is the scope of damage. You must assess the scope of damage related to what is the approximate number of deaths, number of persons injured, number who have disappeared, number who have been displaced, the status and the capacity of the health facilities, the urgent needs, the human and material resources needed in the affected area. Finally, what you need for needs assessment is to assess the secondary health hazards for the population. Is there secondary health hazards for the population? Yes, there might be. As we have mentioned before, the cholera outbreaks that happened during the Yemen war. The rapid needs assessment is very important because it keeps the entire population informed of the changes in the situation, as well as the international community, as well as the helping agencies, as well as organization and coordination for receiving donations and the allocation of the necessary resources. Disaster management, here I have a comment. Disaster management can be nationally, internationally, globally managed depending on the size and impact of disaster. Of course, this is a great comment. Yes, a good example for this is the COVID-19 pandemic. It was globally managed, okay? Others will be according to the area affected. For example, SARS was in Canada, in some Arab countries and Far East countries, okay? So, or if something is nationally, you will manage it on the national level. Thank you for your comment. It is much appreciated. هو بريك الصلاة أظن هيبقى بعد 10 دقايق بالظبط، هيبدأ لمدة ربع ساعة. Okay. Rapid needs assessment. What you are doing, you will analyze the data on 3 core aspects. What are these aspects? What is the health status and risk among the community affected? What are the available health resources and service availability? How is the health system performing during the disaster? The disaster response, it is very important to establish command, communication, and control. This will be regulated through the Command and Control Operation Center, or what we call Emergency Operation Center. Also, the shelters and the protection. How can you well provide shelter and protection for your community? Okay. What is the recovery phase? The recovery phase is the last phase during disaster management. In this phase, action will be taken to repair, rebuild, reallocate damaged home, business, plus restore the health and economic vitality. You must repair everything. When does the recovery phase start? The recovery phase starts when the scene is clear from casualties, or the casualties and or the injured are cleared from the scene, either going to their homes or receiving care in the hospitals. Okay? One of the most measures that is done during recovery phase is the psychological recovery. And the psychological recovery is not done only for victims, it is done for victims and survivors and relief workers. All of those should be offered mental health services during disaster, especially during wars, during earthquakes. You meet very, very critical situations. You see children dying, women dying, pregnant women dying, elderly dying, okay? This is everywhere. Does this have an effect on the mental health? Yes, it has a great effect on the mental health of all the stakeholders. What do you do in the recovery phase. In the recovery phase is material cleanup, environmental and structure safety measures, and recovery of belongings. As much as you can, start to clean up everything. Start to take environmental and structural safety measures temporary, okay, until you finish the temporary. You will start doing permanent safety measures and recovery of the belongings of the community. Rehabilitation and construction. The rehabilitation and reconstruction done during the recovery phase will include health service assessment and reconstruction, structural reconstruction, resuming development of effort, transition from relief to development. This is very, very important in order to cope with the strategy and with disaster and effective management of disaster is to return to development, okay? And the United Nations has released in 2015 the Sustainable Development Goals. Development is a very ultimate and important goal after the end of disasters, okay? Here is an case scenario discussing what we have discussed in the past 2 hours. This case scenario is giving an example for a disaster, an earthquake, which happened in an area. This area was already under war for 20 years, and then the earthquake happened, and it affected it. The earthquake, its magnitude was 6.1 and has 15-kilometer radius. Okay, it leads to deaths, leads to injuries. The case scenario discussed the surveillance efforts, how they did the reporting and the notification of the cases, and how did the watery diarrhea was happened as an outbreak during the disaster. What is important is the objectives of the surveillance system during emergency. The main objective is to reduce morbidity and mortality, and monitoring of diseases, and monitoring of workload. The diseases and the conditions for which you will conduct surveillance for this earthquake scenario. Acute phase of emergency, you will take a systematic first assessment of acute public health events, and then you will put your list according to the epidemic potential, to the ability to cause morbidity or death, to its frequency, to the presence of reliable data. What type of surveillance would you consider? Surveillance, it can be exhaustive or sentinel, okay? According, if all health facilities will participate, it will be exhaustive. If only few selected health facilities, it will be sentinel. Where you will start with implementing this surveillance, you will start with the potential data sources: hospital, health center, community facilities, laboratory, surveys. Once you have a final list of disease and the revised form, what's next? What you should want to do before starting collecting data? You have to make a case definition list. It is very important to make a case definition list. For example, this list. What case definition will allow us to detect an outbreak of type 1 Shigella dysentery as soon as possible? This case definition is very sensitive and non-specific. Bloody diarrhea could be caused by non-epidemic Shigella. So what is the case definition that you will use? Diarrhea with visible blood plus positive stool culture. This one is very specific. What is the demographic and health status indicators that you will use? Here are examples for methods of data collection, okay, and the type of data you will collect. Okay, you will collect demographic data, mortality data, and morbidity data. Is there any agencies or group you may use to help in your surveillance efforts? Of course, Ministry of Health and Population, WHO, NGOs اللي هي non-governmental organization. How can you do rapid health need assessment? What are the immediate public health risks in the affected areas? Wounds and injuries, water, sanitation, and hygiene effect, as we have discussed in the lecture. Diseases associated with crowding, as for example, meningitis, vector-borne disease as malaria and dengue. Other public health risks and consideration due to malnutrition, skin infection, non-communicable disease, mental health, and environmental risk. What are the specific priority intervention for immediate implementation? You have to consider surgical, medical, and emergency obstetric care, immunization, communicable disease surveillance and response, support for infant and young, continuity of care for chronic disease, public health communication, the presence of shelter, the presence of sufficient and safe water supply. By this, we finished our 2 lectures. Okay, I think we can have now a break. ممكن ناخد بريك ربع ساعة، لمدة ربع ساعة للصلاة. حد عنده أي استفسار؟ طيب يبقى بريك ربع ساعة للصلاة وهنرجع بعديه بإذن الله. السلام عليكم. شير لحضراتكم المحاضرة. ثواني بس هنشير المحاضرة. حضراتكم الصوت واصل كده؟ سامعيني؟ سامعيني كده؟ طيب اوكي، هشير لحضراتكم المحاضرة. ثواني بس وشير. طيب هل كده المحاضرة ظاهرة قدام حضراتكم؟ Hospital Emergency Management. طيب المحاضرة ظاهرة. اوكي تمام، نبدأ بسم الله. في حد بيقول مش ظاهر حاجة. طيب الباقيين ظاهر عندهم، واضحة مكتوب الهوسبيتال Emergency Management. طيب اوكي، لو مش ظاهرة المحاضرة حضراتكم اكتبوا لي على الشات. اوكي طيب نبدأ. بسم الله الرحمن الرحيم. احنا دلوقتي هننتقل للجزء بتاع الهوسبيتال ايمرجنسي مانجمنت. ازاي احنا بنعمل ديزاستر مانجمنت على مستوى الهوسبيتال، اللي خدناه المحاضرتين اللي فاتوا. في مربع اسود بيغطي السلايد. طيب بقية الناس عندها مربع اسود مغطي السلايد ولا شايفين؟ طيب اوكي، دلوقتي الهوسبيتال ايمرجنسي مانجمنت احنا هنتداول او هنناقش مع بعض الهوسبيتال ايمرجنسي مانجمنت على مستوى الهوسبيتال ليفل، وليس على مستوى الكوميونتي اللي احنا كنا بنتكلم فيه في المحاضرتين اللي فاتت. ازاي الكوميونتي تمام بيتعامل مع الديزاستر مانجمنت. دلوقتي احنا هنبقى very specific لوضع هوسبيتال ايمرجنسي مانجمنت. طيب المفروض احنا نعرف ايه؟ المفروض ان احنا هنعرف introduction عن الهوسبيتال ايمرجنسي مانجمنت، هنعرف ايه هي الديزاستر بريفنتيف ميجرز، الكي ايشوز في الديزاستر مانجمنت ات ذا هوسبيتال ليفل، والهوسبيتال ايمرجنسي ديزاستر مانجمنت بلان، واخيرا البري ديزاستر فيز، ثم الديزاستر فيز، ثم البوست ديزاستر فيز. كل ده على مستوى الهوسبيتال. طيب نبدأ كده مع بعض بسم الله. During times of disasters, the hospitals play an integral role within the healthcare service system by providing essential medical care to their communities. طبعا المستشفيات بتلعب very important role during the disasters. Hospitals provide essential medical care services to the different communities. Any incident is natural disaster, chemical, biological, radiological, nuclear, or explosive hazards, okay, requires multi-sectorial response. Any response to the disaster must be multi-sectorial. What is the meaning of multi-sectorial? The meaning of multi-sectorial is the integration of the health sector with the other sectors. Okay, sectors responsible for food supply, sectors responsible for sanitation, sectors responsible for the safe water supply. Without appropriate emergency planning, local health system cannot respond to the disaster, cannot deal with this critical situation. So for hospital to respond in an appropriate way to the disaster, there should be emergency planning. Emergency planning before the occurrence of the disasters and not after the occurrence of the disaster. Also, to enhance the readiness of the health facilities and the health system to cope with the challenges and difficulties associated with disasters, the hospitals should have been prepared to the disasters through one important fundamental measure, which is hospital emergency disaster management plan. Each hospital, either on the district level or the central level, should have a hospital emergency disaster management plan. And today we will discuss this plan, how the hospital prepare an hospital emergency disaster management plan. Here we will repeat again what is the most important disaster preventive measures. We have 4 measures: disaster mitigation, disaster prevention, disaster preparedness, disaster response. What are the difference between the 4 terms? Number 1, the disaster mitigation is the measures to reduce the impact of disaster on the community. The disaster mitigation is a broad spectrum term that consists of prevention and preparedness. What is disaster prevention? Disaster prevention is linked and related to long-range policies and programs to prevent the occurrence of disaster event. These policies can be structural or non-structural. The structural, for example, building using material which is earthquake resistant. Okay, non-structures as raising the awareness and health education of the different community to how to deal and decrease the effect and consequences of disasters. Number 3 is disaster preparedness. What is the disaster preparedness? Disaster preparedness is usually related what is the government going to do? What is the organizations, the communities, the individuals, how they respond rapidly and effectively. And it's very important to be rapid and effective. Once the disaster occurs, the response must be rapid and effective. Any delay in the response will lead to major consequences. So disaster preparedness include formulation of viable disaster plans, maintenance of resources, in addition to training of personnel on the plans and the resources that will be used during the disasters. Number 4 is the disaster response. When is the ideal disaster response? The ideal disaster response is prior to and following the disaster. And the measures that is directed during the disaster response is directed towards mainly saving life, protecting properties, and dealing with the immediate damage that results from the disaster. The success depends vitally on good preparedness. Your response to the disaster depends mainly on how good you were prepared to the disaster management at the hospital level. There are 3 key issues in disaster management at the hospital level. First of all is the preparedness. Once we talk about the preparedness, we must mention the risk assessment, the hazard assessment, and the vulnerability analysis. Here there is a very important question. What is the difference between the word risk and hazard? We always, during talking about disaster, we always listen to the words risk and hazard. What is the difference between the risk and the hazard? The risk is please wait 1 second. sorry for the interruption. What is the difference between the risk and the hazard? The hazard is something that has the potential to cause harm. Okay, but the risk is the probability of the occurrence of this harm. Okay, what is vulnerability analysis? Is to identify the vulnerable populations and the groups in your communities that will be more harmed from the disaster. For example, children, babies, elderly, people with chronic diseases. All of these groups are more vulnerable to the disaster. Number 2 is the resource inventory of material, equipments, technical, and human. During the disaster and before the disaster, you must have been prepared an inventory. Okay, the inventory will consist of materials, equipments, any technical assistance or human resources needed for the disaster. The resource inventory will be provided through multiple sectors, including government, private, non-governmental, voluntary agencies, and general public sector. Okay? What is the optimum? Number 3 is the optimum utilization of the available resources. What is the optimum utilization of available resources? Which means using the resources efficiently. Okay, what are the most important resources? The most important resources is water, medical services, fire services, public work, electricity, health services, communication, police, ambulance services. Okay, all of these organizations or sectors are involved in optimum utilization of the available resources. Okay, we will move now to the hospital emergency disaster management plan. There are 3 important phases should be identified while you are doing or while you are formulating the hospital emergency disaster management plan. These phases are the pre-disaster phase, disaster phase, post-disaster phase. What we do in the pre-disaster phase. In the pre-disaster phase, at the hospital level, you have to be prepared for the disaster through 3 measures. What are the 3 measures? Is planning, preparation of written disaster manual, and finally, staff education and training. What is the planning? The hospital plans should be formulated and discussed and approved and then disseminated among the staff working in your hospital. Number 2 is preparation for written disaster manual. Copies of the manual should be available in all areas of the hospital and disseminated between the staff either through the hard copies or the soft copies. Staff education and training, regular staff training should be done by using the hospital, how to use the hospital disaster or emergency manual. Pre-disaster planning. Let's start in pre-disaster planning. What should you fulfill during the pre-disaster planning? The following should be fulfilled during pre-disaster planning. First of all is formation of hospital disaster management committee. You must have a committee in control of the hospital disaster management by the name and description of the tasks of the committee, in addition to how can you access the committee, their telephone numbers, their address, and all their contact information. Then initiation of the center command structure. The central command structure should be initiated. Preparation of job cards. This job card describes what everyone should do and who will do it and when he will do it. Then plan activation of different areas of the hospital. How you will activate the different areas of the hospital in your plan. How can you increase the bed capacity in emergency? What if your bed capacity, your ordinary bed capacity is 300 patients and during the disaster you have 3,000 injured? What you will do? Planning of public information. This is very important. Planning for security of hospitals in emergency situation. How can you secure the hospital? How the staff working in the hospital are safe and secure? And finally, the logistic planning. Here is an example for part of the plans which displays the role and responsibilities of the different essential services during the disaster, including administration, dietary, housekeeping, maintenance, nursing, pharmacies, safety and security, additional services, and here it is listed the roles and the responsibilities, the point of contact, and the secondary point of contact. Here is the emergency preparedness contact, is an example for the emergency preparedness contacts. What are the main components of logistic planning? What if you want to prepare for logistic planning? How can you do this? Planning by planning for communication, stores planning, transportation, personnel planning, and finally financial planning. What is the planning for communication? You have a communication plan. You should have a communication channel from the state level down towards the lower level and backward. Okay, information of hospitals of governmental, private, and non-governmental organization should be all merged at the district level and continuously updated. How can you perform stores planning? Adequate stores of medical items, surgical items should be kept separately in the emergency and marked as disaster store. The activation of this store is only done if the disaster has been notified by the appropriate authority. So this is very important. Emergency transportation and ambulance services. How can you plan for the emergency transportation and ambulance services? Details of ambulance with their four telephone numbers of hospitals and the drivers will be compiled at the district level and should be made available to the district, state level, and even other stakeholders, for example, the police, the defense. Okay, activation of this store also is done only after the disaster has been notified. How can you do personnel planning? Either medical and non-medical staff. All the medical and non-medical staff should know their services in managing the casualties, have their job cards, have the job description. Duty schedule also for standby staff should be available in the control room and command center to call standby staff in case they need them. Financial planning. How can you do the financial planning? It is recommended that during writing your or formulating your disaster plan, you should be in close association with the financial advisors to give their opinions and their input regarding the financial planning. If you do so, the financial planning will be more cost effective and will avoid unnecessary and repeated expenditure. Preparation of written disaster manual. How can you prepare a written disaster manual? Preparation of written disaster manual is very important. Okay? There is certain criteria that you should fulfill while writing the disaster manual. First of all, the disaster manual should be predictable. What is the meaning of predictable? There is a predictable change of management in the disaster manual. It should be simple, avoid complexity, so that the staff can use it and it can work and be functional at the operational level. Then it should be flexible. What is the meaning of flexibility? Flexibility here means that it can be executed at different forms and dimensions of disaster. Flexible, so it can manage any type of disaster. Concise, it should not be very much detailed, and it should focus on clear definition of authority and job description. Comprehensive. The disaster manual should be comprehensive, should be compatible with different hospitals, and there should be inter-hospital transfer policy. Adaptable. It should be also be adaptable for different spaces and different times. Anticipatory. It should predict and should be prepared for the worst case scenario. It should be part of a regional health plan in disaster. We don't work alone. We will work according to regional and international plans during the different disasters. It should make provision for vulnerable groups. You should decide who are the vulnerable groups in your community, and then how could you protect them, and how can you provide the health services of them during the disaster. How can you do staff education and training in the pre-disaster phase? The education and the training of the staff and their specific role is very important during the pre-disaster planning. For example, the major training programs are in the form of disaster drills, partial evacuation, non-evacuation drills, revision of hospital disaster and emergency plan, and continuous staff education. Okay, here's some question that you can test your knowledge about in the pre-disaster planning. Disaster phase, the response phase. What do you do during the response phase at the hospital level? What you are going to do? As we have discussed before, the hospital emergency disaster management plan has 3 phases. What are these phases? Pre-disaster phase, disaster phase, and post-disaster phase. The disaster phase is concerned with the response. Hospitals should have 24/7 emergency care services because their primary responsibility is saving lives. When a disaster strikes, okay, the society fall back upon the hospitals to provide them with immediate and emergency medical services. The hospital has to provide a large number of patients in limited time, and this, of course, sometimes it's beyond its capacity, okay? And then we say that this hospital is in a disaster. Disaster can overwhelm the hospital resources, staff, supplies, spaces, okay? This is why there must be coordination between the different leaders and joint efforts during solving or during managing the disaster. For this, there should be hospital emergency management plan that have a command structure with specific case job descriptions for each task. What are the types of hospital disaster? We have two types for hospital disaster, external disaster and internal disaster. The external disaster, where the source of the disaster is outside the hospital, while the internal disaster, where the source of the disaster is inside the hospital, as for fire, chemical problems. The external disaster, for example, earthquake, flood, blasts. How could you classify this incident? The incidents of Marfa Beirut, the explosion that was in Marfa Beirut. It is, of course, external disaster. What is the hospital networking? You should have during the disaster a functioning networking between the different hospitals and between the different healthcare facilities with dynamic link to provide information. The advantages of hospital networking is analysis of existing resources, knowledge augmentation, and optimum use and utilization of resources. What is the hospital response to external disaster? The hospital response to external disaster is done through two main items: disaster management action plan in hospital and job short for disaster management. What is the disaster management action plan in hospitals? Here can you see how the flow of information and the flow chart which describe what is done from the call that the hospital is receiving a disaster. It is received first of all by the command center, and then the emergency code is declared, and then the triage of the patient is performed. Here are examples for the emergency codes. Here is the expected flow of patient from the triage, emergency patient, stabilization and observation, patients who go to the wards, and the patient who have died. What is the job short for disaster management? The job short for disaster management is describing the job description for each type of services delivered during the disaster. Here are some examples for the job description of different services delivered during the disaster management. Let's see. First of all, commanding centers. The commanding centers should include the resident medical officer and nursing superintendent and the public relation officer. What is mainly the resident medical officer responsible for? He is responsible for arranging senior doctors, arranging with the triage officers, stay in the area of administrative offices, pick up and drop van for doctors, paramedical nurses, and for mobilization. What is the main jobs for this nursing superintendent? She should supervise and identify the nursing needs and allocate extra nursing staff if essential, redeploying existing staff and recalling of staff. What is the main job description of the public relation officer? He deploys the voluntary workers. He details the staff about information from the commanding center, informs the ambulance department with information, take necessary arrangement, establishing information services for relatives and friends of the patients. The hospital administrator or the resident medical officer, he is responsible for the dissemination of correct information to the media, and this is very important. The security office take necessary action during crowd, directs the ambulance in and out of the hospital. All the physical arrangement of triage should be done by security guards. Reception and visitor area maintain registries for victims of disaster, provide necessary instructions to either the patients or their relatives. The triage officer. The triage officer has a very important role in categorizing patients according to the severity of their condition and who requires priority treatment. This role can be played by the resident medical officer, or the hospital superintendent could be responsible as the triage officers. Sometimes we need specialist doctors in specific specialties according to the type of disasters to be within the team receiving the patients. This will include the general surgeons, orthopedic surgeons, physicians, anesthesia specialists, nursing staff. Nursing give first aid treatment, obtain information and fill out available information on disaster tags, maintain the medical records of the victims. Also, nursing assistant to assist the nursing staff during the procedures that they do. Of course, we need housekeeping staff. The housekeeping staff clean the concerned department, okay, and they also remain in their office or in the department until further notice. The ward attenders, at least there should be 4 ward attenders in each emergency area. Patient receiving area, also the clinical epidemiologist plays a very important role in surveillance of communicable diseases after the disaster. The dietary department prepare to serve nourishment to ambulatory patients, house patients, and also personnel. Counseling center, psychiatrists should be available or social worker to help patients and family members for counseling after disaster. The ambulance, of course, its work should be 24/7. Also, it may include mobile ICUs can be available. The mortuary, where the deaths, where we put the dead body and hand over to them, to their family members. Labs, department heads should be notified, and the samples and requests and the analysis should be disseminated, and lab reports should be available on time. Blood bank, at least there should be 2 staff on duty for the blood bank. A list of blood group and products should be available in the unit, and arrange for further blood products if needed. The pharmacy also should work 24/7, okay, and at least with 3 staff on duty. It should report to command center, then remain in the department. A list of drug suppliers that can provide emergency supplies quickly. It should provide necessary drugs and equipment whenever requested. It also should ensure stock of medicines. Nursing in charge should evaluate patients in the intensive care unit for possible discharge and transfer patient out if indicated. Also prepare to admit more critically ill patients from the injured. Send runner to command center or phone for help if needed. The radiology. Once X-ray, CT, and MRI, one X-ray, CT, and MRI technicians at least should be available. The radiologist should be on duty or on call. At least 1 housekeeping staff on duty. Nursing 10 assistants should verify the stocks in the department and maintain proper register for each. Also, dissemination of reports should be done on time. Operation theater. The operation theater should be available. Okay, there should be supervisor or nurse who will supervise the operating room and call all needed personnel after reporting to the command center. Also, the stocks in the operating theaters should be verified, and the check area for supplies and equipment should be done. Assign and direct scrub nurses, notify the triage when operating rooms and recovery rooms are available. Also keep minimum list of supplies on hand and be prepared to process additional sterile supplies quickly. Also notify anesthesists who will maintain adequate anesthesia and drug supplies. The physiotherapy department head or designee will call in their own personnel as needed after reporting to command center. Also, pain management of ambulant patients according to their condition should be provided. Information management and health personnel at the disaster sites. Information management is a very critical and important item in the job description. The command center is responsible for reconfirming the information regarding the scale of the damage and the patient movements, documenting the name, position, and contact number of source of each piece of information, dissemination of information on victim and victim load to the media through media briefs. This should be done through the hospital management. Proper documentation of disaster victims in the hospital is necessary for the identification purposes, needs assessment, also the impact assessment. Also, daily line listing of the patient is very important. What the health personnel should do at the disaster site. Do the health personnel have a role on the disaster sites? Yes. Health personnel are requested to accompany the rescue team, should be trained to navigate disaster site, and should be provided with the required protection equipment. The safety of the health personnel in the disaster scene is very, very important. You all, I think that you all remember what happened at the explosion of the Marfa of Beirut. What happened when they went to rescue the injured? The place exploded, and they died. Okay, so what we say here is safety comes first. Safety comes first for health personnel. Okay, health personnel untrained should not accompany the rescue team. Okay, there should be clarification on the transportation of rescue team member falling victims to the disaster or the secondary events. مهم جدا جدا ان ده يحصل. طيب، خلينا قبل ما ننهي المحاضرة ده، خلينا نرجع تاني ونقول إن أهم حاجات إحنا عرفناها خلال هذه المحاضرة إن في حاجة اسمها pre-disaster phase وفي حاجة اسمها post-disaster phase at the hospital management. What we do at the pre-disaster phase. إيه اللي بيحصل في ال pre-disaster phase؟ ده اللي بيحصل في ال pre-disaster phase. We do 3 items. The 3 items are preparedness, resource inventory, and optimum utilization of available resources. This is done through planning, preparation of written disaster manual, and staff education and training. But what we do during the disaster phase, we do the following. There should be a plan. Number 1, there should be a plan, hospital or disaster management action plan in hospital, and job chart for disaster management. The hospital or disaster management action plan in hospital should describe the flow of patients, how the patient move between the different services, what is the emergency code, what is the type of disaster. What about the job chart for disaster management? The job chart for disaster management describe each job, what is exactly the tasks and the job description that it will do. Okay? Here, the commanding center receives the call and identify whether it is an external disaster or an internal disaster. And based on this, the commanding center will command or will declare the emergency code. Which emergency code? Is it emergency code for fire, or for disaster, or for cardiac arrest, or for violence, or for evacuation? Then the triage will be performed for the patients. Okay, and here are example for the emergency codes. These are the different examples of the emergency code. Okay, and this is example for the triage of the patients, for the codes of triage of the patients. And here is the flow of the patients after the triage, the recommended flow of the patients after the triage. The job chart for disaster management is the job description for the different services delivered during the disaster. What are the different services delivered during the disaster at the hospital level? The different services are services by the commanding center, services by the hospital management, services by the security office, services by the reception and visitor area, services by the patient receiving area. The commanding center includes both the resident medical advisor, the nursing superintendent, and the public relation officer. Okay, and each of which has its own duties and his own tasks, which is documented in the job charts, okay, or job cards. Other services include the dietary department, the counseling service center, the ambulance, the services for the desks, the labs, and the blood banks. Then comes the services delivered by the pharmacies, by the ICUs, the radiology, the operation theater, and the physiotherapy. The last type of services is the information management, which is very critical and should be done by the command center, in addition to the health personnel who will deliver services at the disaster site. What we said for the health personnel at the disaster site is the safety comes first. This is the most important rule. Safety comes first. Okay. The next session, the next two sessions will be with Dr. Nesreen Kamel will join you. And then after these two sessions, I will give you a session of a group of case studies about how different hospitals case scenario response to the disasters at the hospital level. Okay. Thank you very much. If there are any questions, I'm ready. Please, if there are any questions.
Thank you, Dr. Walid.
Thank you, Dr. Nesreen. Goodbye.
Bye. السلام عليكم. إن شاء الله هيكون the break about 5:30 p.m. Hospital emergency management. I'll be with you to discuss an introduction, the Sendai framework for disaster risk reduction, case studies, and discussion points. So, reducing disaster risk is a cost-effective investment. Countries have enhanced their capacity in disaster risk management. There was a global platform for disaster risk reduction and a regional platform for disaster risk reduction. Those helped countries to put policies and strategies to the advancement of knowledge and mutual learning. In 2005, in Hyogo, Japan, there was a framework, Hyogo Framework for Action, 2005 to 2015, for building the resilience of nations and communities to disaster. We hope that by this framework, we reduce the disaster risk. The framework provided a unique opportunity to promote a strategic and systematic approach to reduce the vulnerability and risk to hazards. It identified ways of building the resilience of nations and communities to disaster. However, over the same 10-year time frame, from 2005 to 2015, disasters have continued to affect the well-being and safety of persons and communities. What has happened? 1.5 billion people were affected by disaster. 144 million were displaced. 23 million became homeless. And we lost about $1.3 trillion. So after the global platform, which is the Hyogo Protocol, which were put to reduce the disaster, still there was a lot of losses in face of losing people, displacing people, homeless people, and economic loss. Yes, we will take a break in half an hour, inshallah. Okay. The Sendai Framework for Disaster Risk Reduction, which covered the year from 2015 to 2030, the Sendai Framework was adopted by member states in March 2015 at the UN World Conference on Disaster Risk Reduction in Japan and was endorsed in June 2015. The goal of the Sendai Framework is to prevent new and reduce existing disaster risk. Through what? Through implementation of integrated measures, economic, structural, legal, social, health, cultural, educational, all dimensions that will prevent and reduce the hazard exposure and vulnerability to disaster and increase the preparedness, response, and recovery so we can strengthen the resilience of the countries. So, Sendai Framework applied many measures to reduce the risk of disaster. The following slides shows the main features of the Sendai Framework. There was a shift from focusing on managing disaster to managing risks. So we are working on a wider scope, okay? And we are endorsing in the framework the biological hazards as epidemic and pandemic. And it is a people-centered framework, all hazards, multi-sectoral, with a strong focus on health, which is our main target to study today. Strong focus on health. Health is a key element of the Sendai Framework because the Sendai Framework places a strong emphasis on resilient health system. We want the health system to be able to gain its ability rapidly, reduce the negative consequences, and be able to deal with disaster. In the next two slides, so we developed the Sendai Framework with a goal to prevent new and reduce risk of disaster. We're having strong focus on health. We have 7 global targets to achieve by 2030. What are the 7 global targets of the Sendai Framework? We have 4, which begins with substantially reduction, and 3 beginning with substantially increase. So we want to reduce what? We want to reduce the disaster mortality, of course. We want to reduce the number of affected people. We want to reduce the economic loss in relation to GDP, gross domestic product. We want to reduce the disaster damage to infrastructure, basic services, including the health services. And we want to increase what? We want to increase the number of countries that have national and local disaster risk reduction strategies by 2020, because it was endorsed in 2015. We want to increase substantially the international cooperation to developing countries to complement a national action for the implementation of the framework. And we want also to increase the availability and access to what we call the multi-hazard early warning system and disaster risk information. So there is 7 global targets we are targeting by 2030 within the framework of the Sendai. Let's discuss and try to remember. The global target of the Sendai framework for disaster risk reduction from 2015 to 2030 is targeting substantially reduction of what? Substantially reduction of disaster mortality, number of affected people, disaster economic loss, and disaster damage to critical infrastructure and basic services. Let's try to remember what was the global target for Sendai framework, what we should increase. We should increase the number of countries that have disaster risk reduction. We should increase the international cooperation, and we should make available a multi-hazard early warning system. So can we pass to another point? So this was the Sendai framework with its main features. Main feature, we want to include the biological hazards. We want to be people-centered. Slides, let's remember. As main features, we want to shift our focus to manage risk instead of managing risk to reducing the risk. We want to work on a wider scope, of course. We want to endorse the biological hazards. We want to be people-centered and multi-sectoral. We want to focus on health. Those can be achieved through a global framework, global target. 4 of the 7 global target: reduction, mortality, of course, the number of people, economic losses, and reduction of losses in infrastructure or damage to infrastructure and basic services. And we want to increase the countries with strategies for disaster, increase the international cooperation, and the availability of multi-hazard early warning system. Okay, let's pause to another point. We have the Sendai framework priorities of action. We are going to work on understanding the disaster risk, strengthening the disaster risk governance to manage risk, investing in disaster risk reduction, enhance the preparedness for effective response, build better, back better, and recovery, rehabilitation, and reconstruction. So for priority 1, we want to understand the disaster risks. So we are going to do policies and practices for disaster risk management that should be based on understanding the disaster risk in all its dimensions. We want to strengthen the governance through clear vision, plans, competence, guidance, and coordination. We want to invest in disaster risk reduction through public and private investment in disaster risk prevention. We want to enhance disaster preparedness for effective response and build a better in recovery. How are we going to achieve those priority action in the system in the dimension of health? So in the dimension of health, if you want to achieve the priority one, is understand the disaster risk. How are we going to understand the risk? To understand the risk, we need data and statistics. We can do a statistical model, disaster risk modeling, mathematical model. If we want to strengthen the governance, we can do this through promote transboundary cooperation. If we want to invest in risk reduction for resilience, we need to build safe hospitals and health facilities. We want to increase the access to basic health services through design and implementation of inclusive policies and social safety net to include access to basic health services, maternal, newborn, child health, sexual and reproductive. We want the essential basic health services to continue even in disaster situation. We want to enhance disaster preparedness through safe hospital, promote the resilience of hospitals and other health facilities to ensure that they remain safe, effective, and operational. We want to establish community center for stockpiling of necessary material to implement and risk. We are going to enhance the resilience of the national health system through integrating the risk management into primary, secondary, tertiary healthcare, promoting and enhancing the training capacity, especially on the International Health Regulation 2005 of the World Health Organization. If we want to enhance the preparedness and build back better in recovery, we are working on train the health workforce as we are doing now in disaster response or disaster management, health data, establish a mechanism for case registry, surveillance, and don't forget the mental health to enhance the recovery of the health workforce after disaster. So if you want to remember the 4 priorities for action of the Sendai framework, we have the following: understand the disaster risk, strengthening the disaster risk governance, investing in disaster risk reduction, and enhance preparedness and build back better in recovery, rehabilitation, and reconstruction. This slide shows that the global targets for the Sendai framework are aligned with the SDGs Sustainable Development Goal, especially Goal number 1, Goal 11, and Goal 13. We have to monitor the Sendai framework 38 indicators that are used to track progress in implementing the 7 target. So we have 7 target, 38 indicator aligned with the SDGs. And this is a link for those who want to follow the Sendai framework monitoring. Can you see my slide now? Can you see the slide now? Can you hear me? Yes, okay, thank you. Okay. So we have an example of indicator. I said that the Sendai framework has 7 target, global target, and 38 indicators. I'm not going to present all the 38 indicators. I have presented the 7 global target, but I cannot present the 38 indicators. Those are part of the indicators that are related to health. So if you want to monitor the Sendai framework application or implementation through indicators, we have indicators to measure the number of deaths and missing persons attributed to disaster per 100,000 population. So we are going to monitor the number of deaths and number of missing persons. We want to monitor also the number of injured or ill people attributed to disaster per 100,000 people population. And we want to monitor the number of destroyed or damaged health facilities attributed to disaster. And we are going to monitor the number of disruption to health services attributed to disaster. So those are part of the indicators that are developed to monitor the progress on the global target of the Sendai framework to disaster. The Sendai framework is a framework globally adopted to reduce the disaster. So if I'm going to discuss those indicators and try to remember together part of those indicators, I have presented them as 3 categories, but we can develop 5 indicators from them. Number of deaths attributed to disaster, number of missing persons attributed to disaster, number of injured or ill people attributed to disaster, and number of destroyed health facilities, number of disruption of health service. Those are part of the indicators that we use to monitor the 7 global targets of the Sendai framework for disaster risk reduction. So those were the indicators. How are we in case of those numbers? So to reduce the disaster-related mortality, we have noticed the following, that the average disaster-related mortality per 100,000 population declined from 1.6 in 2005-2015 to 1.15 in 2013 to 2022. There was a decline by 28%. Those are a snapshot of the Sendai monitoring framework in March 2023. Okay. We noticed also that the number of disaster-affected people increased. So the number of disaster mortality decreased by 28%, but the number of disaster-affected people increased from 1,092 between 25 and 2015 to 2,000. There was an increase of 86%. Decline in mortality of 28, increase of affected people by 86%. And of course, the disaster economic loss, there was loss of 0.37%. And as regard the damage to critical infrastructure, there was between 2015 and 2022 over 800,000 critical infrastructure units and facilities, including schools, hospitals, that were damaged or destroyed. More than 12 million educational, health, and other basic facilities were disrupted. So those are the results that was presented in March 2023. As regard the countries that should have, or should develop a strategy for disaster risk reduction, we were in 2015, we were having 55 countries. The countries increased to 126 with an increase of 130%, which is good. Regarding the international cooperation for disaster risk reduction, the international cooperation, unfortunately, for developing countries remains limited only to $304 million in 2021. However, from 25 to 2022, there was 1,742 program and initiative on science and technology and innovation transfer by 39 countries, and there was 33,441 instances of capacity development that were reported by 42 countries. And as regard the multi-hazard early warning system, there was an increase of 114%. Those are the results as regard the monitoring of the Sendai framework. So we have time to summarize before we have minutes to summarize before taking our break. So this is as regard an introduction before starting what we call a case study. We have seen that all globally and regionally we are interested in what we call disaster risk reduction. So we adopted in 2005 what we called a Hyogo framework for 10 years, okay? However, during those 10 years, there was losses. 1.5 billion affected by disaster, 144 displaced, 23 homeless, and continues the losses. So we adopted another framework, which is the Sendai framework for disaster between 20 to 2030. Okay, the Sendai framework has target, global target. The global target are 7. Those 7 global target include target to reduce, of course, economic losses, mortality, number of affected people, and increase of countries which have disaster risk reduction, which have international cooperation and multi-hazard warning. Then we discussed what we call the priority of action, and we had 4 priority of action: to understand the disaster risk, to strengthen governance, to invest in disaster risk reduction, to enhance preparedness. And those are the details of the priority of action. And then we have showed that the Sendai framework is aligned with the SDGs 1, 11, and 13. And then we said that we have 38 indicators to monitor the 7 targets. I presented some of the indicators, and I presented the results of the March 2023 snapshot of the Sendai monitoring framework. In disaster response phase, we should focus on executing the disaster plan. The initial primary concern is fulfilling the basic humanitarian needs of the population, of course, as well as limiting the loss of life. Type of medical care will depend on the disaster type. A substantial task within the response phase, which is very important to coordinate the effort between the facility and the regional level and, of course, the national level. In general, there are 2 response tactics. Can you guess? What are we going to do in a response phase? We have to do one of 2 options. Shelter in place, okay? We have to help establishing a safe location within the facility, remaining in place until all is clear. Or choose between a shelter in place and evacuation, leaving the facility or region affected by disaster. According to situation, of course. So the 2 response tactics, we remain in place or we evacuate, okay? We have a case study of the earthquake that was conducted or was done, hit Turkey in last year or last 6 months, on 6 February 2023. There were 2 consecutive earthquakes with high magnitude in south and southeast region of Turkey. Those 2 major earthquakes were followed by 200 aftershock. We had a lot of deaths, 44,000 deaths, and 108,000 injuries. 2.2 million people were displaced from disaster zone to safer provinces. Okay. We are going to have a break in 2 minutes. Okay. We are going to read the case and then discuss the case after the break. We are going to have a break for 15 minutes. Okay. And then return back to complete the discussion of the case. So there was a temporary disruption that occurred in health services immediately after the earthquake. Healthcare workers worked long and tiring shifts. Temporary hospitals were built very quickly. Okay. 74,000 healthcare workers practiced disaster medicine. The health organization in Turkey safely transported patients out of the disaster area by airline and highways. What I present here is a case study, a paper published, a retrospective study that was conducted aimed to evaluate the emergency response to 125 pediatric patients identified in the first 20 days. Those 125 pediatric patients were under the age of 18 who arrived to the emergency department. But on the 6th day after the disaster, after the earthquake, the number of cases peaked, a sudden increase of the number of cases. The mean age of them was 7.9, so they were pediatric children. Most cases had non-traumatic internal disease. 81% of them had non-traumatic internal disease, and more than 97 were discharged. The main presentation of the most common diagnosis was upper respiratory tract infection. And most of them were discharged with a drug prescription. Soft tissue injury was the most common diagnosis of traumatic cases. Extremity injuries were the major body zone injured in children. Many admissions in the first hours after the disaster to hospital located in the disaster area, and that there are more admissions at Far Hospital after the first day. After the first day, the number of cases started to peak in the Far hospitals. So pediatric patients who were affected by earthquake increased the workload in hospital far from the disaster area. Accordingly, Far Hospital should take precaution in terms of the number of healthcare workers and equipment because the workload grows in the following days after earthquake. So we're going to have our break and come back in 15 minutes. Thank you. Okay, let's continue. This is the. Are you back? Okay. Before the break, we discussed. Before the break, we discussed the case study. Okay, about the earthquake which was in Turkey in February. Okay, we knew that the problem in the case study that there was a lot of deaths, a lot of injuries, and the healthcare workers had a lot of stress. They worked long and tiring shift. But mainly the problem is that the hospitals that were far from the disaster area were affected on the 6th day. Okay, so we have to take care that if a disaster is in one place, localized in one place, and we are far, or we are working far in a hospital which is far from the affected area, we should expect from this case study, from their lesson learned from the past experience of Turkey, that the number of cases are expected to peak in the following days in the far hospital. So we have to be prepared as well. Okay. And then the injuries were mostly simple, يعني respiratory syndrome, and most of the children were sent home. Okay. So let's discuss the context of the study. Okay. What was the context of the study? It's mainly the earthquake that was in Turkey in February. So in the 6th of February, there was 2 consecutive earthquakes in the southeast region and south of Turkey. There was a lot of deaths, 44,000 deaths, and 108,000 injuries. And as for the people who were displaced, there were 2.2 million people. Okay. If we want to know the type and aim of the study, it was a retrospective study which was conducted, and why we conducted this study, why we did this retrospective study. We want to learn. We want to to know what happened, to gain experience, to know what went well and what not. We aim to evaluate the emergency responses that we gave to 125 pediatric patients in the first 20 days. So the finding of the study, the finding was that most cases had non-traumatic internal injuries, upper respiratory tract infection. Soft tissue injuries was the most common diagnosis. Extremity injuries was the diagnosis of the trauma. And the conclusion, the lesson بقى. The workload grows in the following days after earthquake. So accordingly, far hospitals should take precaution in terms of the number of healthcare workers and equipment, even though they are far from the area affected. This was our first case. Now we are going to discuss our second case. This is a case study on application and prospect of a mobile hospital in disaster response. The disasters such as earthquake and the epidemic usually lead to a large number of casualties accompanied by disruption of the local medical institution. So we need a rapid response of the medical assistant and support. Mobile hospitals may be the solution, okay, which may play an important role in saving casualties and alleviating the shortage of medical resources. Okay. The mobile hospital can be composed of a medical unit, a technical support unit, a ward unit, and a life support unit. The mobile hospital has advantages of good mobility, strong adaptability to the environment, rapid deployment, complete medical function, and early treatment of the wounded. The mobile hospitals can be categorized into 3 types: terrestrial, floating, and flying. The terrestrial mobile hospital is the most common type, which includes tent hospital, vehicle hospital, and shelter hospital. The shelter hospital could respond immediately to disaster calls and immediate departure from the disaster zone when the situation happens. While the tent hospital has a large available space, low requirement, and its disadvantages are long in withdrawal time. Some countries use the shelter combination, mainly United States and France. Tent combination were represented by Russia and Italy. The shelter and tent combination were represented by Germany and China. This is an image of the tent hospital that were used by Chinese medical team in Nepal earthquake rescue. This is an image which is drawn from a paper, Application and Prospect of a Mobile Hospital in Disaster Response. And then we have a rescue material delivery vehicle. This is an image from the same paper as well. As regards the floating hospital, it is a self-contained, sea-going medical facility. Floating hospitals could only reach destination near water. The hospital ship named Mercy is used in the United States for world disaster rescue and humanitarian operation. Okay, this is the Mercy in the United States. And Peace Ark is the name of the China hospital ship that has carried out dozens of humanitarian missions since its commission, treating over 180,000 patients around the world. The flying hospital had been adopted by many of the world governments. The flying hospital could provide what? Surgical hospital services, acute medical care for disaster situation, or humanitarian relief. Aeromedical evacuation provided fast transportation of wounded persons. Okay. Those are examples of disaster response using the mobile hospital. We have in this slide the disaster type, the date of the disaster, the site of the disaster, and the type of mobile hospitals that were used in this disaster. So we have the flood in 2001 in America, we used tent hospital. Earthquake in 2003 in Iran, tent hospital. The tsunami in Indonesia in 2004, tent hospital. The earthquake in 2010 in China, shelter hospital. In COVID-19 in 2019, China, vehicle hospital. Okay, those are examples of mobile hospitals that were used. In 2006, 35 firefighters were trapped during a forest fire. The China International Search and Rescue Team transferred these 35 severe casualties to Peking for treatment by using a modified airline. Okay. In 2010, France proposed air transportation and delivery of medical equipment through some mobile hospital in Haiti earthquake. As well, the Canadian medical team delivered mobile hospitals through air transportation in the same disaster. In 2013, during the Philippine Super Typhoon disaster rescue, China hospital ship, which is we called before Peace Ark, was deployed in the Philippines to provide humanitarian medical relief. So we are proposing in some response phase of disaster in some countries, we used the mobile hospital. But what's the problem? There is a problem, of course. There is a problem of limited mobile, or we can call it challenges. there is a problem of limited mobile transportation. After a disaster, it is very important to deliver the mobile hospital to the disaster site, which is not always easy. When the railway is damaged, the transportation time of the mobile hospital will be delayed, which may result in missing the time and losing lives and losing people and losing time to rescue them. For example, during the Yushu earthquake in China, the transportation of a shelter hospital rushed to the disaster site overnight, driving 53 hours and 2,350 kilometers to reach the disaster area. In Nepal earthquake, due to imperfection of the equipment, independent operation cannot be performed in the mobile hospital. So one time we had the problem of the road transportation. Another time we had the problem of the imperfection of the equipment. We couldn't conduct the operation. There is a growing need to formulate unified standards for mobile hospital so as to achieve standardized and unified management in the disaster site. So we need to formulate unified standards, especially during the international rescue operation. The design and use of mobile hospital should be the focus of future research so that mobile hospital can better adapt to the need of the disaster rescue. In addition to the basic operation unit, inspection unit, emergency unit, ward unit, support unit, technical support unit, we can add specialized treatment units, including eye unit, obstetric and gynecology, pediatric, infectious department unit. This is we propose. In 2015, in Nepal earthquake, the mobile hospital established by medical team from China, Russia, and other countries added what we call the specialized treatment unit, which effectively improved the rescue efficiency and won the approval of the local population. There was an acceptance because it succeeded to save lives. The application of machine learning, which is the future, have been increasing in the mobile hospital. We can use the machine learning in medical imaging, telemedicine. This technology will be an important sign of future mobile hospitals. As regards the telemedicine has the following advantages. It can improve the uneven distribution of regional medical resources, reduce the working pressure on medical staff, shorten the distance between the medical staff and patient, provide sometimes needed surgical consultation and monitoring. So doctors can call each other, can take consultation, can relieve pressure, can shorten the distance between the staff and the patient. During COVID-19, the China Mobile and China Telecom have applied the 5G technology in telemedicine in a hospital in Wuhan. A company has already developed what we call an artificial intelligence CT diagnosis technology to assist in COVID detection. The artificial intelligence system could make acceptable diagnostic decision within 20 seconds with an accuracy rate of 96%. Excellent. So, if we want to discuss the above case study about the use of mobile hospital in response phase of some disaster. We have advantages. We have discussed some advantages. Can you remember? Can we discuss them? We mentioned that a mobile hospital has the advantage of good mobility, strong adaptability to the environment, rapid deployment, complete medical function, early treatment of the wounded. Okay. But what? Before what? Oh, before, however, we had to mention the types. The types that were discussed above of the mobile hospital, they were categorized into 3 types: terrestrial, floating, and flying. The terrestrial mobile hospital, which is the most common type, include tent hospital, vehicle hospital, shelter hospital, and so forth. And the terrestrial was modular. The flying hospital could provide surgical hospital services and acute medical care in disaster situation or humanitarian relief. The floating hospital is self-contained, sea-going medical facility. Floating hospital can reach destination near water. Okay. Now we came to the limitation of the mobile hospital before discussing the future of the mobile hospital. The limited, we mentioned that it took one of the mobile hospital took about 53 hours to reach its destination. It had to pass more than 2,000 kilometers, which is so long time. Limited mobile transportation when the road, the railway is damaged. The transportation time of the mobile hospital will be delayed, which may result in missing the time of rescue. Type. If we want to discuss example and best practices of disaster response of mobile hospitals, we discussed tent hospital, shelter, vehicle hospital in some disaster type during the above dates and the above disaster. In 2015, the Nepal earthquake, they added a specialized treatment unit which won the approval of the local people. This was one of the best practices. In COVID-19, we added the 5G technology in telemedicine in a hospital in Wuhan. So what's the future of the mobile hospital? Use of machine learning, medical imaging, diagnostic, telemedicine. We had artificial intelligence for CT diagnosis with 96%, as I said, in 20 seconds. So recommendation to maximize the benefit of mobile hospital. If we want to recommend after discussing the above case, how to maximize the benefit of these hospitals. We should focus on future research. We should apply, as we said and as we discussed, unified standards. And we should share lessons and best practices. So this is for our first lecture. Let's share our second lecture. Can you see my screen? Can you see my screen, please? Okay, thank you. Thank you. Okay. In our second presentation, we are going to discuss how to prepare ourselves, our hospital, for an emergency. This is the WHO report on hospital emergency preparedness. We have things to discuss, very important when we are preparing for a disaster. Introduction, management, communication, human resources, logistics, hospital, pharmacy, services, hospital laboratory, essential support services, continuity of essential healthcare, psychological and social support services, patient management, and surge capacity. All these are chapters. Each one is chapter in the WHO hospital emergency preparedness, which is a shared reference for all of us and all of you. Okay. Hospital and other healthcare facilities play a critical role in responses. It goes without saying. Hospitals are very important, as you see. Hospitals should be able to adapt to the specific challenges of any emergency. hospital management should establish mechanism for developing and implementing a hospital emergency response plan. We all heard about hospital emergency response plan. We should have one. Hospital personnel should be fully aware of their role, prepared and respond to an emergency through training to perform the necessary action, and at the same time provide day-to-day hospital services. We should be prepared to communicate very well during an emergency. So let's discuss in details every chapter to be able to gain a perspective of how to prepare ourselves. To be prepared to face any risk or emergency, a hospital should have what we call a hospital emergency committee, responsible for developing the hospital emergency risk management program, of which an emergency response plan is an essential component. So we have a committee that will develop what we call the emergency risk management program, from which we have an emergency response plan. Those are the guidelines of the WHO. The hospital emergency committee establishes what we call an incident command group, which is responsible for adapting the hospital emergency response plan, and from which we are going to develop an incident action plan that will specify the task needed to respond to the current emergency. So we have a committee, hospital emergency committee, that will establish what we call incident command group, that will develop an incident action plan based on the hospital emergency response plan. I hope you can follow. The basic requirements that are stated in the WHO guideline that we should have hospital emergency committee, hospital emergency risk management program, incident command group, hospital emergency response plan, and incident action plan. The hospital emergency committee, the risk management program, the response plan, the incident command group, the incident action plan, all ensure the coordination of all the activity required to prepare for and respond to an emergency. We need the very good coordination in the management section. Okay? The task of the hospital emergency committee, first of all, it will establish the risk management program. Okay? Then it will develop the hospital emergency response plan and the incident management group. The details task, it will assess the risk, identify measures to reduce the risk, identify the required resources and activity, identify sometimes point of weakness such as required staff training, and it will develop the response plan. Ensure that each hospital department has its emergency response plan. Each department know what should its role during each stage. Should define the procedures for activating the plan. The activation of the plan should be consistent. The emergency response plan and the incident action plan should be consistent with the strategies and policies implemented outside the hospital. We should be consistent with our health authority, the national effort. Okay, we are part of it. We should implement guidelines for staff safety. We should review the communication system. We should review the logistic and information management. The management has a lot of work to do in these situations. The incident command group perform a broad range as well of activities needed to respond to a specific emergency. What are they going to do? Leadership and making decisions, of course. Acquire and deploy the necessary resources. This is their logistic function. We had an incident command group that are responsible to take the leadership role, logistic function to acquire the resources, ensure availability and allocation of skilled personnel, which is called operational management function, pay bill and contracts, which is an administrative function. The incident action plan that will be developed by the incident command group is a document. It is essentially an adaptation of the hospital emergency response plan. This is an action plan from the response plan. It specifies how the hospital should respond to an emergency. The role and responsibility of the key department and individual are detailed, as well as any action plan. As you know, we should mention in the action plan, we should state in the action plan what are the activity, who is responsible, when, but also we should say the nature and the magnitude of the emergency prediction, the estimated increase in the total patient load during the emergency, the estimated increase in the equipment, supply, medicine, staff. All of the above were about the management section only in the emergency preparedness of the hospital. As for the communication section, we have another requirement. Through their service delivery function, hospitals have privileged access to the community, and therefore, information issued by the hospital regarding risk reduction should be consistent with information provided by health authority. As we said before, if we have a plan, our plan should be consistent with the National Health Authority. If we have to communicate information, our information should be consistent as well with the health authority. Information about the emergency and the risk it entails should be communicated as soon as. Any information should be communicated as soon as, because we are in an emergency situation. Okay? And through a single source. Those are the guidelines. The guideline said that information consistent with the national authority as soon as, through a single person, communication activity will be undertaken and coordinated, of course, under the umbrella of the incident command group. The basic requirement in this section is to have what we call a hospital risk communication strategy. And we should understand the type of information to be communicated about the prevention of injury, illness, and deaths, and about the activities required to respond to the emergency. During communication, to prepare ourselves in the preparedness phase of the disaster for the communication component, we should develop in the hospital emergency response plan the communication component. We should prepare what we call job action sheet for the role and task of the staff responsible for the communication. And if the staff need training, we should ensure that they receive this training. We should identify what are the sources of information and what are the type of information that should be told. And we should appoint official hospital spokesperson sometimes to address the public on behalf of the hospital. For the external communication, we should determine what information in the public is likely to need during an emergency. We should determine on accessing hospital services and routine public health program. Those may be the type of information that are needed. We should inform the public about how to reduce the risk during the emergency, the procedure needing for dealing with the media. We should develop a plan for internal communication. What are the information that need to be circulated to the hospital staff, the patient, the visitors? We should inform all the hospital staff about their safety measures. Brief the hospital staff about the procedure required for two-way communication, and be prepared with a surge capacity plan or contingency plan with human resources in case of shortage. Those are the preparedness tasks for the communication. As regards the recovery phase in the communication, we want to learn from our experience, okay? So we should maintain and adapt the communication with the public and the hospital staff to minimize risk of injury, and we should communicate how to access hospital services, and we should assess our operational performance because we want to see what went wrong and what are we going to learn. We don't want to repeat our faults. Okay, we want as well not to forget about the psychosocial support in the recovery task. Now, as regard the human resources, we have discussed two components of the hospital emergency preparedness: management and communication. What about the human resources, which are very important and the critical role during this disaster or emergency or incident? So we need to protect the health of the hospital staff, because protection of their health is a priority concern. A shortage of staff due to the increased demand for services must be anticipated, and a plan to cope with this shortage. So we need to take care of their health, prepare ourselves for shortage, think about if we need additional personnel, how are we going to get them during the emergency? Maybe through the retired hospital staff, maybe through the university staff, the students from Faculty of Medicine, Nursing, Public Health. We are going to have a case study on this issue at the end. Maybe we need to enroll extra staff to perform a specified role or to conduct supervision or on-the-job training. Staff assigned to those tasks lack specific competence, maybe need training. Maybe we need community support for our staff to do simple work with them, provide assistance with domestic care for their children, transportation to the hospital. Those tasks that the community can provide to the staff can give the staff flexibility for working irregular shift and longer hours. Okay. So in the preparedness tasks, we have to have a component, of course, in the emergency response plan for the human resources. We have to prepare what we called job action sheet to describe the role and task during the emergency. And we have to have a mutual aid agreement with Ministry of Health, healthcare facilities, university. As we said, we may need additional staff. We should be prepared that during emergency, our staff is not enough. How are we going to increase our staff? How are we going to get our additional staff? If we had previously signed agreement with university or other agency, private sector agency, it will be very simple to acquire additional personnel. Develop a training program. Okay, human resource needs training all the time. Update training, continuous medical education. Develop procedures to recruit more staff, additional staff, volunteer staff, and maybe we need expert for training, for treatment, sometimes hospital staff, as we have seen during the COVID pandemic. We need to have a plan to support them mentally, their psychosocial support. We need to think about, so in the preparedness, we think about all the issues. Maybe we need an emergency fund. We used it during the pandemic for paying staff in an emergency situation, for expanding them, train the staff on the human resource management rules, surge capacity for staff shortage to increase the demand. In the recovery phase, we are going to assess our performance in the human resource component and to gain our lesson, to learn our lesson, what went right and what don't. And of course, we are not going to forget about the psychosocial support for our staff. These are the human resource component. As regard the logistics, which are very important component during an emergency, as you are seeing now, we need resources. We need human resources, and we are going to need the logistics, and we are going to need pharmacy services, we are going to need laboratory service and the logistics to provide the right resources at the right time, in the right quantity, in the right place. For right, in one statement. in order to satisfy the increased demand being made on the hospital by an emergency. Okay? How are we going to achieve this? Provide right resources, right time, right quantity in the right place. We have, of course, a plan. Okay? We have to assess our current logistics system. In any plan, we conduct what we call a situation analysis to assess our system. Okay, then we develop standard procedures for emergency procurement of supplies. And what are we going to do, and to anticipate what are we going to do for additional requirement or additional supplies from where we are going to bring them. In the recovery phase, we should assess what we have done, and we should restore our basic health services. For the medicine, to make appropriate medicine and other pharmaceutical products available in the hospital in time of an emergency, we need to develop the pharmacy component of the hospital emergency response plan. We need to have a job action sheet for all staff members responsible for providing the pharmacy services. We need to provide the pharmacy staff with training. We need to decide what are the medicine or the pharmaceutical products that are essential during this emergency. We have to be consistent as well with the Ministry of Health recommendation. We have to develop and implement BARDO standard operating procedures and supply chain for acquiring, stocking, and distributing the necessary supplies. If stocks of pharmaceutical supply, such as personal protective, antimicrobial, antiviral, are outside the hospital, we need to say exactly how they can be accessed by the hospital. Okay? We need to develop also, as we have seen in the pandemic, a plan for the role of the pharmacy in providing medicine for outpatient and home-based care. We need to have a plan for the role of pharmacy in receiving, storing, and sorting donated medicine. We should have a plan. How are we going to deal with the increased demand for pharmaceutical services? All this we should think about it in the preparedness phase before passing to the recovery phase, in which we are going to restore our routine pharmacy services after reviewing what we have done and to see what have done good and what we went good and what doesn't, because we are going to learn our lesson in the recovery phase, without forgetting the psychosocial support and the need of the pharmacy staff, if any. As for the laboratory services, we want to provide laboratory services in support of the hospital preparedness. Develop the laboratory, we had to develop, of course, the laboratory component. As for all the previous component, we need to develop the laboratory component of the hospital emergency response plan. We need to prepare the job action sheet, okay, for the staff of the laboratory. We need, if they need training, they should receive their training. We should prepare protocol for sharing essential information. We should identify what we called referral laboratory and establish agreement of understanding with them for transportation and testing of specimen during the emergency. We need to establish, of course, agreement, memorandum of understanding with supplier and the healthcare facilities to receive the laboratory supply. We need to develop the procedures for evacuating the laboratory in order to ensure staff safety and while assuring the continuity of the routine laboratory services. So referral hospital for the test, supplier agreement with suppliers for the supplies of the laboratory service, and sometimes we are forced to stop for safety measure to stop our services. What are we going to do if our services is stopped? We need to ensure that the laboratory staff are trained in applying infection prevention control, of course. We have to establish a contingency or surge capacity plan with human resources to manage for staff resources and check that standards are being applied. Of course, in the recovery phase, we are going to refill our stocks and prepare ourselves to maintain our routine laboratory services as before the emergency. So we have discussed the management role, we have discussed the logistics, the pharmacy services, the laboratory services, the human resources. Now, as regards the essential support services, what are the essential support services that we need to continue? We need to continue the safe food, water, and nutrition services. We need to ensure that the safety of the hospital and all the people inside the hospital. We need to provide laundry and the cleaning services and manage the hospital waste. Those are essential support services that need to be continued during the emergency. How are we going to guarantee this? We need to provide effective repair and the preventive maintenance services. And for the burial of the bodies, we need to have a system to ensure that it is being done properly. So the essential support services from water, food, laundry, waste, bodies, we need to develop the support services component and think about it during the hospital emergency response plan. We have staff working in the essential support services. We should prepare for them job action sheet. We should train them if they need. We should scale up essential support services if we have limited resources. How are we going to conduct or to ensure the continuity of the essential services? Through reviewing the existing systems and protocol for managing kitchen stock, for example, make agreement arrangements with suppliers. This is very important. Identify major security problems that may arise and draw up an action plan to resolve them. Identify the security equipment needed and if we need an extra equipment. Ensure that adequate maintenance services are available. Identify the requirement of water, heating, ventilation, air conditioning, electricity, and make, of course, arrangement with suppliers. Identify serious maintenance problems that may arise during an emergency. In a plan, we should think about all and estimate what is going to be done and how are we going to deal with, in summary. Draw up an action plan for urgent scaling up of the maintenance capacity. Ensure that the policies and emergency response plan of the local community and the government with regard to management of the dead. Ensure, of course, the availability of bags for bodies and body identification procedures. Ensure availability of mechanism for tracking patient and dead bodies, which is not easy in the emergency situation, because what we think is easy in the usual situation may be not during an emergency, may be very challenging and very difficult to provide water, food, bodies, identification, patient tracking, psychosocial support to families, recovery task as all the recovery in the recovery phase. We are going to discuss the recovery phase in details before in the next 2 hours. In the recovery phase, mainly we think about the psychosocial support, about gaining our supplies, about rehabilitation of any essential equipment, about learning the lesson. As regard the continuity of essential healthcare services, we need to ensure that the hospital as a critical component of the health system contribute to the continuity of the essential healthcare services. So we have essential health services that should be continued. We should identify, in consultation with the Ministry of Health, the essential routine services to be maintained, allocate human and material resources accordingly. We should determine the procedures for management of non-essential services, including referral to other facilities or level of care, or deferral until a decision is taken to resume non-essential services. So the planning will be through the Ministry of Health to decide what are the essential routine services that we need. During the preparedness phase, we should ensure that the hospital emergency plan include strategies for ensuring continuity of essential service for routine patient, and at the same time, delivery of medical care needed by crisis patient. We should ensure the availability for acquisition, resupply, and availability of equipment, supplies, and other material resources. We should establish, as we said before, agreement, memorandum of understanding with the various private and public sector healthcare facilities, because we may need to refer patient during an epidemic to continue the essential healthcare services in other facilities. In the recovery task, we are going to see what we have done. We are going to discuss, to have a report, to discuss what we have done, and we are going to learn our lesson. As regards the psychosocial and psychological and social support services, we want to reduce the post-traumatic psychic trauma that may affect some people, some staff, patient, community. What are we going to do? We have to establish a hospital psychosocial team with job action sheet that ensure they receive training in order to enhance their ability to fulfill their role in implementing the hospital emergency response. So we have to have a team with job action sheet. We have implement procedure to identify patient from family member, from hospital staff, that may be at a higher risk of suffering from mental distress and other mental problems. And then ensure that those patients or families or hospital staff are aware that psychosocial support is available and that they know how to access this psychosocial support team member through the meeting or telephone. Implement agreement with community psychosocial services. Maybe we need to provide additional support to our staff or additional staff. We want to ensure that psychosocial support services we need them to be provided at alternative care site, not at the hospital site. Bardo, in the recovery phase, we have done what we call psychological and social support. We are going to see what went good, what went right, what was not right, what we should not do the next time, do evaluation and replanning. As regard the patient management, I think this is the final component of the handbook or the guideline for the hospital emergency preparedness. This section of the patient management is to ensure that the hospital can achieve safe and effective patient management, not only in routine circumstances, but also when emergency make increased demand on hospital resources and capacity. Okay? So we should ensure that national patient management protocol for emergency are widely available to relevant staff. خلاص؟ يعني في management protocol available to staff. For patient not requiring hospital admission, develop or review mechanism for referral. If we have patient that doesn't need to be admitted, maybe we conduct referral, send him home. We should designate a reception area to be used for patient and ensure that it can function independently of other hospital areas and activities, such as the cleaning room or equipment. We put a cleaning equipment, okay? We should designate a suitably equipped and secured triage area. We should ensure that staff receive training in working in triage area. We should develop procedures for the management of patient traffic flow within and outside the hospital by creating two separate channels, as we have done during the pandemic. Develop procedures for the management of outpatient care in such a way as to avoid exposure of an uninfected patient to the risk of infection. So we have a triage area, we have patient traffic flow two-way. We should ensure that outpatient is separated to avoid infection or spread of infection. I think we have done all of this during the pandemic. As for the recovery task, as a part of an overall hospital review, we should assess the hospital operational performance in implementing patient management protocol and procedure, and if necessary, update this protocol and procedure. We should conduct psychosocial support to the staff, and we should activate procedure for routine patient management activity. The last activity will be the surge capacity. To enable the hospital to expand its ability to manage a sudden or rapidly progressive surge in demand for hospital services created by an emergency. This is very challenging. We have to make or update an inventory of all available resources: organizational, public and private, primary, secondary and tertiary level of care, physical, healthcare establishment, equipment, human staff, material, supplies. Develop strategies to provide surge capacity in an epidemic or other emergency for human resources, staff, bed, equipment, supply, and other resources, extra quantities of personal protective equipment. So we should be prepared. How are we going to prepare ourselves? We are going to plan, estimate our additional needs, and make agreements with suppliers to ensure that the hospital receives the necessary supplies and resources early enough and in sufficient quantity to ensure the hospital self-reliance during emergency. We should determine whether and to what extent mutual agreement and synergies with other healthcare facilities, the Ministry of Health, private sector agency, universities, and other organizations could make available additional personnel. So we wanted to increase our surge capacity through agreement with supplier and the provision of additional personnel, as we have seen during our planning for the human resources. As a part of an overall hospital review, we can assess the hospital operational performance in providing a surge capacity and, if necessary, update this plan. So let's summarize what we have discussed so far before taking the lecture of Dr. Wala, inshallah. I'm going to write to Dr. Wala to be available at in 3 minutes. So as a summary, we have discussed what we called a hospital emergency preparedness. Okay, hospital emergency preparedness is a guide from the WHO, shared from the WHO, covering the following area: the management, the communication, the human resources, the logistics, the pharmacy services, the laboratory services, the essential support services, the continuity of essential healthcare services, psychological and social support, patient management, and surge capacity. Each chapter or each section wants us to know the basic requirement, what we should do in the preparedness phase, response phase, and recovery phase. But I have discussed only the requirement, the requirement of the preparedness phase and the recovery phase. In the management, we should have what we call the committee, hospital emergency committee, that will assign an incident command group to develop an incident action plan. The communication, we should know what we say, what we should say. Have a spokesperson, share information, external or internal, as soon as possible, depending on reliable information. As regard the human resources, we should be ready for additional needs, for additional supply of human resources. Maybe we can get them from the university, from other healthcare facilities, from students. We should prepare the logistics and be able to make agreement with suppliers. The pharmacy, we should agree with we know what are the guidelines of the Ministry of Health regarding the required medicine. The laboratory, we should have agreement with referral laboratory, with suppliers for laboratory tests. As regards the essential support services, we should prepare ourselves to continue the essential support services from food, water, laundry, burial, and we should be able to give all the staff, the community, the patient, the psychological and social support they need through preparing ourselves with a team to support them. Maybe we need alternative site, maybe we need additional people, personnel. We should be able to continue our essential healthcare services and conduct the patient management properly into channel of traffic. We have to be able to increase our capacity during the emergency by estimating our additional requirement. So now Dr. Wala is in. She should be able to continue the next lecture with Dr. Wala. Thank you, Dr. Wala.
اوكي ثانك يو دكتور نسرين. السلام عليكم. دلوقتي هنكمل مع بعض بإذن الله الكيس ستاديز اللي احنا اتفقنا عليها نشتغل عليها في الهوسبيتال emergency management. ثواني هشير بس اللينك. طيب حضراتكم كده شايفين البرزنتيشن واضحة قدامكم ولا لأ؟ hospital emergency management case studies واضحة ولا لأ؟ اوكي تمام. طيب نبدأ بإذن الله. We are going to discuss a group of case studies addressing the response phase for hospital emergency management. Okay, the first case study هي في الحقيقة الكيس ستادي دي كانت أصلا عبارة عن فيديو يوتيوب. تمام، أنا كتبته أو حاولت إن أنا يعني أحوله السيناريو لأن يعني خفت بصراحة الفيديو ما يشتغلش، بس سايبة لحضراتكم الفيديو هو عبارة عن دريل. حضراتكم ممكن تأكسس الفيديو من اللينك اللي أنا سايباه على يعني في أي وقت حضراتكم تحبوا إن انتوا بقى تتفرجوا على الفيديو براحتكم بقى، بعد ما نخلص ممكن تبصوا عليه. ايه اللي احنا هنشوفه او هنسمعه في الكيس ستادي دي او الكيس ستادي دي بتناقشه. In this case study we are examining the external disaster management drill carried out by Kenyatta National Hospital KNH Management Unit. Kenyatta Management Hospital is the largest referral and teaching hospital in Kenya with 50 wards, 22 outpatient clinics, 24 theaters, and an extant emergency department and over 6,000 staff members. احنا جايبين دريل حقيقي حصل في مستشفى في كينيا. المستشفى دي تعتبر من أكبر مستشفيات الريفيرال جوه كينيا، فيها 50 وورد، فيها 22 outpatient clinic، وفيها 24 operating theater and an accident and emergency department و over 6,000 staff members. طيب ادي الهوسبيتال من بره، هما جايبين صورة ليها. In this case ايه اللي بنبريزنت في هذه الكيس؟ A chemical. In this case we present a chemical, biological, radiological and nuclear mass casualty incident drill carried out by the KNH management unit. The drill is part of monitoring the hospital preparedness in response to similar types of crisis. حضراتكم لو شفتوا الفيديو هتلاقي هي عبارة عن دريل بيشترك فيه التمثيل بتاع الدريل ده. الهوسبيتال ستاف نفسه هو بيمثل أدوار البيشنتس والريلاتيفز، تمام، وكل واحد بيقوم بدوره، وبيبدأ الدريل ده باتصال تليفوني بيصل للمستشفى بيبلغ إن في chemical, biological, radiological and nuclear mass casualty incident حصل في المدينة، وإن المفروض إن الكيسز هيتم إرسالها على ال KNH. The drill aims to stimulate a situation where a hazardous chemical substance has been accidentally released in a nearby residential area, resulting in multiple casualties. الدريل ده هو بيسيميوليت وضع بيحصل فيه hazardous chemical substance، تمام، بتطلع فجأة في residential area، منطقة آهلة بالسكان، وده طبعا هيتسبب في multiple casualties زي أي incident بنقابله. طبعا هو هنا بيمثل لي external disaster لهذه المستشفى. As the drill begins, a loud Syrian blares across the hospital grounds, alerting the staff of the unfolding emergency. The hospital administrator, along with the resident medical officer, swiftly disseminates correct information regarding the disaster to be presented to the media, ensuring that accurate information is shared. فهنا الدريل عند بداية الدريل بتبدأ السرينة، تمام، بتاعة الألارم بتاعة المستشفى، صوتها بيبتدي يظهر في كل مكان، تمام، بتنبه الستاف إن في emergency في المستشفى. مين اللي قام بالديسيمينيشن بالانفورميشن للميديا؟ قام الهوسبيتال ادمنستريتور ومعاه الريزيدنت ميديكال اوفيسر، هم اللي قاموا بالديسيمينيشن of the information to the media عشان المصداقية وعشان الشفافية بتاعة الانفورميشن. ثم بعد كده the security personnel اللي هم أصلا trained in disaster management protocol spring into action. They take necessary steps to control the crowd, ensuring the safety and order within the hospital premises. They also direct the incoming ambulance carrying the injured victims, skillfully clearing the way and ensuring a smooth entry. في السلايد ده هو بيشرح دور السكيورتي بيرسونال في الدريل. هم عملوا ايه؟ السكيورتي بيرسونال وهم اصلا اشخاص مدربين على الديزاستر مانجمنت بروتوكول، واحنا عارفين ان احنا بيبقى معانا الديزاستر مانيوال اللي فيه الجوب كوردز لكل سيرفيس هيعمل ايه، ومن ضمن السيرفيس ده هي السكيورتي سيرفيسز. السكيورتي سيرفيسز أول ما طلقت إن في ديزاستر اكسترنال ديزاستر ابتدوا يكنترول الكراود، يتحكموا في الزحمة وينظموها، ينشور السيفتي والأوردر والنظام جوه المباني التي تخص المستشفى. مش بس كده، هم اللي ابتدوا يوجهوا عربيات الإسعاف القادمة اللي شايلة الضحايا بطريقة ماهرة جدا عشان يضمنوا سموث انتري لعربيات الإسعاف. Meanwhile, the reception staff promptly sets up a register specifically for the victims of the disaster. They record the necessary details, ensuring accurate documentation and tracking of the affected individuals. في نفس الوقت الريسبشن ستاف ابتدوا يجهزوا الريجستريز والريكوردز للفيكتيمز اللي جايين وقت الديزاستر. واحنا قلنا تجهيز الريكوردز ده هي حاجة مهمة جدا، بأسماء لو كان معاهم الاي ديز بتاعتهم، لو كان معاهم لو في اي بيانات ممكن تتاخد منهم، عشان خاطر اهالي الضحايا ده هي بعد ما هيعرفوا بحدوث الديزاستر هيبتدوا كله يهجم على المستشفى عشان عايز يطمئنوا على ذويهم. تمام، ابتدوا هم يريكورد كل الديتيلز الاساسيه وينشور ان التوثيق ده كان دقيق، ويبتدوا يتراك الافكتد individuals. As the injured victims are brought into the hospitals, the doctors quickly assess the situation. They identify the patients who require immediate and specialized care, triaging them based on the severity of their injuries. This crucial step ensures that those in critical condition receive priority attention and treatment. زي ما حضراتكم شايفين السلايد ده هي بتوصف ان الانجرد فيكتيمز ابتدوا يجوا المستشفى، وبسرعة الدكاترة ابتدوا يعملوا assessment of the situation. They identify the patients who required immediate and specialized care. ابتدوا يعملوا triage للpatients, sorting of the patient according to the severity of their injuries and according to the priority of the treatment. They did so, and this is a very important step to ensure who is in critical situation and needs priority attention and treatment. Working alongside the doctors, the nursing staff springs into action. They provide aggressive first aid treatment to stabilize the patients, ensuring that their vital signs are stable before moving them to the appropriate departments for further care. The nursing staff also prepares the necessary lab slips and X-ray requests, ensuring that the patients are swiftly directed for diagnostic tests and imaging. In this slide describes the role of nursing staff, okay, in providing first aid treatment, stabilizing patients, measuring the vital signs, referring patient to the appropriate departments. Also, the nursing staff prepares the lab slips, prepares the X-ray request, also ensures that the patients are correctly directed for performing their diagnostic test and radiological procedures. Within the emergency area, the ward attendants are prepared and ready. They ensure the availability of essential equipment such as wheelchairs and stretchers, allowing for the smooth movement of patients. Their presence and assistance further enhance the efficiency of the emergency response. داخل emergency area الستاف المسؤول عن ward attendants اللي احنا بنسميهم ward attendants. Ward attendants are mainly responsible for the availability, ensuring the availability of wheelchairs, helping patients to move, to put patients on stretchers, smooth movement of patients. These are the main responsibilities of the ward attendants. And in the lecture, we mentioned that there must be at least 4 ward attendants in every emergency area. Their presence and assistance further enhance the efficiency of the emergency response. Without the ward attendants, despite that they are not providing medical services, but their presence is very crucial, okay? This will improve the efficiency of the emergency response regarding the timing of the services, okay? Also, throughout the drill, the hospital ambulance service operates seamlessly. The 24/7 service ensures that ambulance, including mobile ICUs, are readily available. The ambulance drivers and emergency technicians are well trained and occupied to handle such situations, ensuring swift transport of the injured patient to the hospital. And here they mention the role of the hospital ambulance services, which works for 24/7 without any stop. Also, the ambulance services may include mobile ICUs, okay, according to the type of the disaster, the magnitude of the disaster, the severity and types of the casualties. The ambulance drivers, in addition to the emergency technicians in this hospital, are well trained and occupied to manage these situations, allowing transport of the injured patient to the hospital in a very efficient and effective way. As the drill concludes, the hospital management unit gathers to assess their performance. They review the action taken and identify areas for improvement. It is noted that one crucial action, triage, was initially missed in this scenario. The importance of triage is emphasized and steps are taken to ensure that it is incorporated in future drills and disaster management protocols. After the disaster ended and the disaster was recorded by the camera, they saw the record to evaluate the disaster measures that they done. Okay, the hospital management unit gathered to assess the performance. During assessment of the performance, we identify the strength points as well as the weakness point. One of the major weakness points that was identified during this drill, that the triage was missed. The triage was missed mainly at the site of the disaster. Okay, there was no triage done at the site of the disaster, and this may have affected the transport of the severely injured patients at the correct time. The transport of the patients must reflect the following golden rule: the right patient at the right time in the right place. Okay, absence of triage at the scene of the disaster misses this point. The right patient will not be transferred at the right time in the right place. Also, they emphasize on the importance of the triage, and they have assured the steps will be taken to ensure that the triage at the site of the disaster will be implemented in the future drills, so that if a disaster actually happens, the triage will take place in a right and correct way. Overall, the CRPN mass casualty incident drill at Kenyatta National Hospital serves as a valuable exercise in testing the hospital external management preparedness. As we said before, in the preparedness stage or in the pre-disaster phase stage, training the hospital staff on disaster management is very critical and is very important. You must train your hospital staff on the manual and on the equipment and on the resources. One of the very important methods of training your staff is drills, is making drills or applying drills at your hospital. It highlights both the strengths and areas for improvement, allowing the hospital to enhance its response capabilities and ensures the safety and well-being of its patient and staff in the face of similar crises. The drills allow us to know where is the strengths, where is the areas that need more improvement, okay? And this will reflect on the capabilities and will ensure both the safety of the patients in addition to the staff. This is the link for the video of the Kenyatta Hospital drill. You can watch it at whatever time you want on that YouTube. It is present for free. It's about a 15 minutes video. The first question here, what is the type of disaster presented in this case? And please write in the chat box. Is it an external disaster or an internal disaster? Is it an external or internal disaster? This was a disaster describing a chemical leakage or chemical explosion outside the hospital. Okay, is it an external or internal disaster? If you know the answer, please write it on the chat box. Internal. Okay, why internal? We have mentioned that internal disaster, the source of the disaster is inside the hospital. Here, the source of the disaster was outside the hospital. Let's see كده. Okay, let's see here. Where is a hazardous chemical substance has been accidentally released in a nearby residential area, resulting in multiple casualties. So the source of the disaster is outside the hospital. Okay, will you consider again your answer? Is it, yes, it is an external disaster. It is an external disaster because the source of the disaster was outside the hospital. Thank you. Okay, the second question. What should be the hospital disaster response in this case? In this case, what is the response of, thank you, Dr. Gies. Okay. What is the hospital disaster response in this case? What we do in case of response to a disaster? We will apply two prepared, okay, issues. What did we prepare that we will apply it during the response to the disaster? If anyone have a clue, please write it in the chat box. What we will apply. تفتكروا حضراتكم هنطبق ايه اثناء الريسبونس؟ احنا كنا محضرين ايه اول ما تحصل الديزاستر المفروض احنا نطبق؟ What do you think we will apply? البلان. Excellent. Thank you very much, Dr. Gesson. Exactly. We will apply our hospital disaster management action plan in hospital. We have already a written manual with a detailed plan. Who will, and thank you, Dr. Abdelrab. I'm sorry, I can't read the complete. Abdelrab Al-Amir, thank you, Doctor, for your answer. Yes, we will implement our disaster management action plan in the hospital, and we will apply our shop short. What is our shop short? Our shop short is a description of the tasks that each one will carry out during the disaster response. Let's move to the next question. What is the color of the hospital emergency code that should be used in this case? What do you think? Which color we will apply as an emergency code in this case? This is a chemical explosion. What is the color of the code that we use? If you know, please write it in the chat box. Okay, yellow or orange. Excellent, excellent, excellent. Excellent, دكتورة رنا, دكتورة أريج, دكتور جاسم, yes. The color will be orange or yellow. According here, it will be orange. Okay, orange is the correct answer. Thank you very much. Okay, Dr. Murtada, thank you. And Dr. Maha, excellent, excellent. Okay, correct responses. Orange will be the emergency code of choice in this case. Okay, let's move to the next question. And Dr. Abdurrahman, thank you. According to the disaster management plan, who will start acting after the first call that reported the incident in the hospital? بعد أول مكالمة جت بتريبورت الانسيدنت to the hospital, who will start acting? Who is in charge to act after the first call? And it was in the flow chart that we have discussed in the post lecture. Okay, who is in charge after receiving that there is an external disaster? If you know, please write it in the chat box. If you know the answer, who will be in charge? من سيكون المسؤول أو مين اللي هيتولى قيادة الأمور بعد ما أول مكالمة جات لنا بتبلغنا إن في حادث أو في major incident أو في disaster. تفتكروا حضراتكم مين who will be in charge according طبعا to the disaster management plan? Who will be in charge? Any clue? Any answer? Security, manager of hospital. Manager of hospital will be responsible for dissemination of information, for example, to the media. Okay, Dr. Ali? Security are responsible to be to call the police, for example, if there is an internal disaster, to control the crowdness, to deal with the relatives of the patient. But who will be in charge? I will make it more easier. Who is in command? Who is in command? Registration and recording stuff? No, there is more specific. We said that ambulance, not the ambulance. Duty manager is the one who is command, is responsible. هو المسؤول، هو في ايده القيادة، هو اكيد الكوماند سنتر. احنا اتفقنا ان لازم يبقى فيه كوماند سنتر، هو اللي بيدي الاوامر. اوكي، هو اللي بيدي الديوتيز. والكوماند سنتر ده بيبقى مكون من ايه؟ مكون من 3 اشخاص. It is composed of الكوماند سنتر، مكون من ال resident medical officer، مكون من ال public relation officer، ومكون من nursing superintendent. Okay, يبقى it's very important to know that who is in charge, who is in command, who carry out the responsibility. It is the command center. Okay, there must be a command in any disaster management. There must be a leader. There must be a center اللي احنا بنسميها زي ما بنسميها أوضة العمليات كده، أو غرفة العمليات المركزية. Command center, yes. Yes, Dr. Murtada, command center, true. Okay, let's move to the, as we see in the flow chart, the first call comes. Who will receive the call? The call will be received by the command center, and then the command center will start activating, okay, will start activating the action plan for disaster management. The command center is responsible for activation of the pre-prepared action plan for disaster management. What is the recommended flow of patients in this case? What is the recommended flow of patients? As you know, that the flow of patients is according to the triage of the patient. You have first to perform a triage of the patient. That means sorting of the patient according to their case, severity of their case, and according to the priority of treatment. This is a flow chart, okay, describing how is the flow of the patients. Okay, القدرة على الحركة، تمام. Some patients will need emergency services, others will need stabilization and observation, others will be admitted in the wards, and others will be dead, and we will stop over there. Okay. So the recommended flow of the patient after triaging the patients, they will be directed according to their priority code to the corresponding service. For example, if they need the emergency department, they will be referred to the emergency department, or if they need observation and stabilization, or if they need observation and ward admission, or if they are dead. Okay. This is the code for triaging the patients. It may be different from one hospital to another, but this is an example for coding the priority for patient treatment. You would see that the dead patients receive the code black, and emergency or immediate services needed when needed receives the code red, and in between is the code yellow, green, and blue. The next question, what is the missing action that was not seen in this case before transporting the injured to the hospital? احنا اما شرحنا الكيس قلنا ان كان في حاجة مهمة جدا كانت المفروض تحصل في مكان الحدث وما حصلتش، واحنا ذكرناها فرانكلي كده جوه الكيس، واحنا طبعا لو كنا شفنا الفيديو كانت هتبقى احلى، لان هي مبينة عربيات الاسعاف وهي بتاخد البيشنتس، وان ده ما حصلش. What is the missing action؟ اللي من حضراتكم يعرف ايه هو الميسنج اكشن يا ريت يكتبه لنا في الشات بوكس. What was the missing action in this case؟ تفتكروا حضراتكم كان ايه هو الميسنج اكشن اللي كان في الكيس سيناريو ده؟ First aid? No, it was not the first aid. It was something before even the first aid. Okay, something is done before even the first aid. What is the first thing we do when we go or when we reach the scene of the disaster? What we have to do with the patients? What we have to do with the patient? I will make it easier. Excellent, Dr. Abdelrab. The triage. The thing that was missing is the triage, sorting the patient according to the severity of their condition and the priority of the treatment. Why triage? Triage to save time. Triage to make the right patient at the right place in the right time. Okay, so triage was a very important step that should be done before transporting the patient by ambulance. Okay, to know which cases needs priority and immediate care. Okay, so it's right, the triage. Triage, yes, thank you, Dr. Farida, it is triage. Okay, let's move to the next question. Enumerate the categories of the individual who were present around the patient receiving area at the moment the ambulance arrived to the hospital. ساعة وصول العيانين أو المصابين لمكان الحدث كان في مجموعة معدة إن هم مستنيين البيشنتس. أنا ذكرتهم وأنا بذكر الكيس سيناريو. ممكن تقولوا لي كاتيجوريز منهم، يعني مين اللي كان في انتظار البيشنتس؟ مين؟ If you know please write it in the chat box. مين المجموعة الهيلث كير بروفايدرز، أو حتى ممكن ما يكونوش هيلث كير بروفايدرز كانوا موجودين في مكان الحدث؟ مين يا دكاترة؟ مين يقدر يقول؟ نيرسز، اكسلنت دكتورة فريدة. مين تاني كان منتظر البيشنتس في مكان الحدث؟ وقلنا النيرسز قامت بالفيرست ايد، وهم اللي كانوا بيقيسوا الفيتال ساينس. الريزيدنتس، اوكي دكتورز ثانك يو فيري ماتش. ذا ريزيدنتس ميديكال yes and دكتور عبد العزيز right. The resident medical officer was present. مين تاني؟ who else was present? Who else was present in this case? I can go back to the slides to see. I can help you by sharing with you again who was present. Here we can see the drill. When the drill started, the resident medical officer disseminate the correct information, and the hospital administrators, the security personnel did their job. The reception staff did their jobs. The injured victims were brought into the hospital and they were triaged inside the hospital. Okay, and the nurses worked alongside with the doctors. In the emergency areas, there were the ward attenders, also the ambulance services personnel. Okay, so who else was present? Yes, not social worker. The case didn't mention social workers, but mentioned another type of paramedics. Yes, reception staff. Excellent. Who else? Who else? Security. Excellent. Dr. Abdurrahman. The security did their job, and the management staff. Okay. The hospital administrator, yes, was present. Very good. Who else was present? Hospital administrator and the resident medical officer disseminated the information to the correct information to the media. Who else was present? Let's see who else was present. Security, nurses, doctors, ward attendants, proxy of the injured. We forgot to mention the relatives of the patients. The security was controlling the crowds from the proxy, relatives of the patients. Very good. I think that we have more answers that what is written in the key answer. Okay. In this case, who should deal with the proxy of the injured and why? Who should deal with the proxy of the injured? Who? Please, if you know, write it in the chat box. Who should deal with the proxy with the relatives of the injured and why? If you know the answer, please write it in the chat box. Who, in case of, okay, let me see your answers. Police officers, security, yes, very good. Police security first. If they fail to deal with the relatives, if it failed to deal with the relatives and deal with the crowdness and deal with the noise or any interruptions, the security has to call for assistance from the police officers. If you want to write answers, please write it in the chat box, in the chat. Okay. Thank you very much for your correct answers. Okay, police or security officers, thank you very much. And why? Security personnel, as they are interrupting the work of the healthcare providers, the crowdness, the noise, and sometimes they make fights with the doctors. So we will, the security, yes, the security. And if they fail to do their job, they can call for the police for additional help. Okay. According to the job chart for disaster management, what were the actions that were fulfilled in this case? What is the strength points in this drill? Okay. If you know, please write in the chat box. What do you think? There are more than one strength point in this case that can be lesson learned for us for any drill or for any disaster management. What is the strength point in this drill in disaster management? What do you think? Please write your answers in the chat box. What do you think was the strength point? I will mention one strength point and then you can mention the rest. One of the strength point is the presence of the hospital administrator and the resident medical officer to disseminate the correct information to the media. And this is an excellent point because to prevent spread of faulty information, okay, and to provide correct risk estimation, correct risk communication, not underestimating or overestimating the risk. There must be someone responsible for disseminating the information to the media and the public. This is a very good strength point in this drill. Okay, what else? Does anyone has noted a strength point in this case? What about the security? Was the security job a strength point or a weakness point in this case? What do you think? Security was a strength point or a weak point? Please write if it's a strength point, the security was a strength point or a weak point. Strengths, yes, thank you. Thank you. It was a strength point. Yes, they did their job very good. They managed the crowdness, they dealt with the relatives and the proxy of the patients, they smoothened the way for the ambulance services and the ambulance cars to enter. Thank you very much. The security work was a strength point. What about the nursing? The nursing staff job, okay, was a strength point or a weak point in this case? The nursing tasks was a strength point or a weak point? Let's see كده. Return to the slide mentioning the job of the nurse. What did the nurses do? Or the nursing do? Okay. Here it is. The nursing staff springs into action. They provide aggressive first aid treatment to stabilize the patients, ensuring that their vital signs are stable before moving them to the appropriate departments for further care. The nursing staff also prepares the necessary lab slips and X-ray requests, ensuring that the patients are swiftly directed for diagnostic tests and imaging. According to what we mentioned, was the nursing services as strengths, or yes, of course, thank you, doctors, it was a strength point. Okay, thank you, doctor. Also, the ambulance services was a strength point. Let's see the ambulance service. They worked 24/7. Okay, let's here bring the ambulance. The ambulance services work 24/7, including mobile ICU. Ambulance drivers and emergency technicians are well trained and equipped to handle such situations. So the ambulance was a strength point. Thank you very much. Okay, let's move to another type of service. Okay. What about the reception staff? Did they did this job or not? Let's see. Meanwhile, the reception staff promptly sets up a register specifically for the victims of the disaster. They record the necessary details, ensuring accurate documentation and tracking of the affected individuals. Was the reception staff, their work was a strength point or a weak point in your opinion? Please tell me in the chat box. Do you think that the reception staff with their work was a strength or a weak point in your opinion? Okay, excellent, strong, strength. Okay, very good, excellent. The security personnel, and we, I think that we mentioned it, and their work was a strength. Security service was a strength point. Okay, thank you. Okay, and the hospital administrator and resident medical officer, they disseminate the correct information. What was the weak point in this case scenario? I will bring it for you. The only weak point, okay, that was addressed is that the triage is the triage. يبقى triage at the scene was a strength point or a weak point. Please mention your answer in the chat box. The triage at the scene was a weak point in this drill or a strength point? Weak. Excellent. Thank you. I think also staff should be responsible. Commonly, there is an officer responsible for the triage. There is someone known by name and is responsible for the triage, either on the scene or in the hospital. The triage at the hospital was done, but unfortunately, the triage at the scene was not done. Okay? Thank you very much. Okay. Let's continue our questions. So here we mentioned most of the strength points that was in the drill, including, yes, the triage was missed. Yes, thank you. Thank you, doctor. And this was the weak point in this case. Okay, here we finished the first case scenario. Now we will discuss the hospital response to the internal disaster. What we have discussed before, okay, working in HEG was for all code. Yes, موسم الحج is a real challenge for all types of disasters, and of course HEG is an external, if there's a challenge or is a problem, it will be an external disaster. HEG is a great opportunity to apply to know how to prepare a management emergency action plan. Yes, HEG is a good model for crisis management. Thank you, doctor. Hospital response to internal disaster. What is the hospital response to internal disaster? First of all, what is an internal disaster? Internal disaster is a disaster where the source of the disaster is inside the hospital. Here, this is a news, an online news that shares us that patients were wheeled outside in their beds during a fire at Royal Stock University Hospital. Okay? This is an internal disaster. What to do for management of internal disaster? 5 steps are done. Okay, thank you, doctor. All staff should be responsible for his job description, for sure. It's a must. 5 steps for internal disaster management. What are the 5 steps for internal disaster management? What if an internal disaster happened inside my hospital? Number 1, press the disaster alarm from the source. Someone, anybody present in the source can press the alarm. Then press the disaster alarm from the source. This is the first step in any type of internal disaster. Okay. Second step is that information should be passed through phone to the disaster management commanding center again and again. The commanding center. The information should be passed to the commanding center by any staff from the concerned department. The commanding center will announce the particular emergency code by any staff from the concerned department. Then the emergency code will be announced at once. What is the third step? Turn off the lift and even the electricity if needed. Evacuate the patients or personnel from the source. Immediate evacuation of the patients and then the personnel from the source. Open the fire exit. If this hospital has a fire exit, you have to open it and direct the patients to use it. What about the bedridden patient? Shift the bedridden patient to a nearby safe zone. To the nearest safe zone, you must transfer the bedridden patients. Okay. What is the fourth step? The fourth step is the sequence. We are still in the third step. What is the sequence of evacuations? Patients in immediate danger should be removed first or should be transferred first, followed by ambulatory patients, followed by semi-ambulatory patients, and finally the non-ambulatory patients. Okay, what is the step number 4? In case of fire, depending upon the nature, extinguisher should be applied by the staff available there. According to the type of the fire, the extinguishing efforts, the right extinguishing efforts should be applied. Also, the hospital security teams should control the crowd throughout the evacuation process. The crowds resulting from the evacuation process should be organized and controlled by the security teams. Police and fire force should be informed by the security officer, who should call the police and fire force. The security officer is the one who is responsible for calling the police and fire force. Also, turn off the power supply to the source if needed. The last step in internal disaster management is that the hospital management is responsible for passing the messages to the press and media. The hospital management is responsible for passing the messages to the press and the media, exactly as the external disaster. Once all the patients have been evacuated, now the staff can leave the source. Further extinguishing work should be carried out by the fire force. When the situation is under control, announce code green. So code green is announced when the scene is clear, when everything is under control. These are the 5 steps in management of internal disaster. Let's see a case. Okay, the case study number 2 is about internal disaster management. Please carefully listen to the case to answer the following questions. Okay. It is a busy evening at Mercy Hospital, a renowned medical facility known for its exceptional patient care and efficient internal disaster management protocol. The hospital is filled with nurses, doctors, and staff attending to the needs of their patients. Suddenly, a nurse named Sarah noticed a concerning situation unfolding and quickly realized that immediate action is required. مستشفى اسمها ميرسي، والمستشفى دي معروفة إن هي مستشفى ديزاستر مانجمنت. في اليوم ده المستشفى كانت مليانة filled with nurses, doctors, staff attending to the needs of their patients. فجأة ممرضة اسمها سارة حست إن في وضع مقلق، والوضع ده محتاج immediate action. Let's see what will happen next. Sarah rushes through the bustling corridors. She spots a suspicious individual attempting to gain an unauthorized access to a restricted area of the hospital. Recognizing the potential threat, she promptly activates the hospital emergency response system by alerting the hospital security team. سارة شافت suspicious individual بيحاول يدخل لمنطقة restricted area جوه الهوسبيتال وهو ما عندوش authorized access للمنطقة دي. هي حست إن دوت threat، وبسرعة راحت بلغت الهوسبيتال security team. ده اللي عملته سارة. The security team responds to the nurse alert, assessing the situation and determining the appropriate course of action. Realizing the severity of the situation, they initiate a code black emergency response, indicating an internal disaster requiring immediate attention and heightened security measures. السكيورتي تيم فورا استجاب للالرت بتاع سارة وخلى اعلن emergency كود بلاك. تمام. وده بيindicate ان في internal disaster اللي بتتطلب immediate attention and security measures. Following the activation of the code plaque, the hospital's internal disaster management plan is set into motion. The security team cooperates with local law enforcement agency, promptly notifying the police about the situation unfolding within the hospital premises. على طول بعد الاكتيفيشن بتاع الكود بلاك، السكيورتي تيم تعاون مع اللو انفورسمنت ايجنسيز والبوليس سيتويشن، وابتدى عشان خاطر يروح الهوسبيتال بريمايسز ويتاكد ايه اللي بيحصل. طيب دلوقتي الصوت واضح ولا في مشكله؟ طيب احنا لسه ما قلناش حاجه غير ان البوليس جه، ان بعد الكود بلاك البوليس جه وابتدى يستكشف ايه اللي بيحصل. اوكي simultaneously. دلوقتي الصوت واضح ولا في مشكله؟ طيب كويس الحمد لله. Simultaneously, hospital staff members are mobilized and deployed to secure the affected areas, ensuring the safety of patients, visitors, and staff. Nurses, doctors, and other medical professionals work in with security personnel, following established protocol to maintain order and protect the well-being of everyone within the hospital. ابتدى الجميع يتعاون مع بعضه عشان خاطر يسكيور الافكتد اريا، واهم حاجه كانت السيفتي اوف patients visitors and staff. مين اللي تعاون؟ nurses doctors and other medical professionals. هم تعاونوا مع السكيورتي بيرسونال ان هم ينفذوا البروتوكولز اللي متفق عليها اصلا for the safety and the sake of everyone. As the police arrive at Mercy Hospital, they coordinate with the security team and hospital administration to assess the situation and devise a comprehensive plan to neutralize the threat. The police, armed with their expertise in crisis response, worked with the hospital staff to ensure a swift and effective resolution to the internal disaster. طبعا كان البوليس وصل المستشفى وتعاون مع السكيورتي تيم والهوسبيتال ادمنستريشن عشان يعملوا اسسمنت للسيتويشن وينفذوا الكومبريهنسيف بلان عشان ينيوتراليز اي ثريت موجود جوه المستشفى. Throughout the incident, communication channels remain open between the hospital administration, security team, and law enforcement. Updates are shared in real time, enabling all stakeholders to stay informed and make well-informed decisions to ensure the safety and security of everyone involved. كان أثناء ده كله كان effective communication ما بين الهوسبيتال administration security team والبوليس حصل بطريقة very effective. مش بس كده، ده كمان الابديتس كانت شيرد مع كل الستيك هولدرز المتعلق بيهم الامر. كده الكيس بتاعنا بتاعت الانترنال ديزاستر بتقول لنا as the situation is brought under control. بعد ما السيتويشن بقى under control, the hospital administration conducts a thorough debriefing session to evaluate and refine the internal disaster management procedures. Lessons learned from this incident will be used to enhance the hospital response capabilities, ensuring an even more efficient and effective response in the future. لو حضراتكم هتلاحظوا هتلاقوا إن دايما بيتعمل evaluation أو debriefing، تمام، بعد أي disaster أو بعد أي دريلي عشان خاطر نعرف إيه ال points of strengths and the point of weakness أو ال areas اللي محتاجة improvement. إحنا مش بنبليم حد، لا إحنا عايزين نعرف إيه ال areas اللي محتاجة improvement عشان نتجنب أي challenges في المستقبل. يعني بناخد lessons learned من التجربة. مش بس كده، the nurse Sarah is commended for her quick thinking and decisive action in alerting the security team about the emergency. Her adherence to established protocol played a vital role in mitigating the potential threat and safeguarding the hospital staff, patients and visitors. كمان سارة اتكرمت واتشكرت وكانت acknowledge للثينكينج بتاعها والاكشن اللي اخدته في الوقت المناسب، تمام، والتزامها بالبروتوكولز المتعارف عليها في مثل هذه الحالات. The incident serves as a reminder of the importance of robust internal disaster management protocols. Mercy Hospitals remains committed to prioritizing the safety and security of its premises, refining its procedures to ensure the highest standards of patient care and employee well-being. طبعا هذا الحادث بيفكرنا دايما بالالتزام بالinternal disaster management protocol. الميرسي هوسبيتال ادت لنا موديل كويس جدا جدا كلنا ممكن حذوه في الانترنال ديزاستر مانجمنت. طيب what is the type of disaster presented in this case؟ الكيس اللي احنا بنتكلم عنها ده هي، يا ترى ايه هو التايب of disaster اللي احنا اتكلمنا عليه فيها؟ هل هو internal disaster ولا external disaster؟ ممكن حضراتكم تكتبوا لي في الشات. excellent دكتور جاسم internal فعلا، دكتورة ملك internal تمام، اوكي internal، دكتورة ريم، دكتورة هبة internal تمام، حلو جدا جدا excellent. دكتورة مها internal. حلو جدا. يبقى التايب اوف ديزاستر هي internal disaster. ليه internal disaster؟ لأن كان السورس اوف disaster inside the hospital. اوكي، جميل جدا يا دكاترة، حلو جدا، ممتاز. طيب ندخل على السؤال التاني. What is the color of the hospital emergency code that should be used in this case? What is the color of the emergency code that was used in this case? black. excellent دكتور جاسم. black دكتورة ملك. دكتور فرحان. اوكي، black. excellent. excellent. حلو جدا جدا، كله correct answers. يبقى كان الكود declared في هذا الوضع كان black emergency code. اوكي، طيب السؤال اللي بعده. Was the nurse duty to report the incident to 911? If the answer is no, who should be in charge of reporting? 911 اللي هي تمثل البوليس. هل دلوقتي السؤال مكون من حاجتين، هل النيرس كان دورها ان هي تريبورت ده للبوليس؟ طيب لو لا، مين اللي المفروض يبقى دوره ان هو يريبورت للبوليس؟ ممكن حضراتكم تجاوبوا لي في الشات بوكس. was the nurse هي اللي المفروض تنوتيفاي البوليس؟ yes or no? was the nurse responsible for no? excellent. طبعا no. مش المفروض ان النيرس هي اللي notify. excellent. the security is the one who is responsible. excellent answers. okay, no, it is not the duty of the nurse. who is responsible for calling the police is the security. no, it is the responsibility of the security personnel. excellent. who should be passing the information to the news or the media? لو حضراتكم عارفين please write it in the chat box. who is responsible for passing the information to the news or the media in this case? admin. yes, administration. excellent. okay, anyone has another answer? the administration. excellent. excellent. or the public information officer. excellent. okay, يبقى المانجمنت or الادمنستريشن او الببليك انفورميشن اوفيسر they are the one who are responsible for passing the information to the news or the media. Thank you very much. Let's move to the next question. What are the steps that should be taken in such type of disasters? هنا بيقصد بال5 steps بتوع internal disaster management. What are the 5 steps? pressing the alarm. Information should be passed to the disaster management commanding center. Declaring the emergency code. Step 3, turning off the lift. Evacuating the patients. And step 4, if there is fire, the extinguisher should be available. Okay, the hospital security team should control the crowdness. Turn off the power supply if needed. And the last step, which is the hospital management is responsible for passing the messages to the press and the media. And once all the patients are evacuated, now the staff can leave the source. Okay, and when situation is under control, code green is announced. Let's move to case study number 3. It is a very short case and we will have short answer questions on it. Okay, please carefully listen to the case. On 4 August 2020, a large amount of ammonium nitrate stored at the port of Beirut, مرفأ بيروت, in the capital city of Lebanon, في لبنان, exploded, causing at least 218 deaths, 7,000 injuries, and $15 billion in property damage, as well as leaving an estimated 300,000 people homeless. The blast was so powerful that it physically shook the whole country of Lebanon and is considered one of the most powerful accidental artificial non-nuclear explosions in history. We all saw الحدث بتاع مرفأ بيروت. What is the type of disaster presented in this case? If you know, please write it in the chat box. What is the type of disaster presented in this case? Is it an internal or external disaster? Okay, external, excellent, external, excellent, very good, external. External because the source of the disaster was outside the hospital, was in support of Beirut, okay? The second question. What should be the hospital disaster response in this case? What is the disaster response in such case? What should be the response will be in the form of 2 items. What are the 2 items? If anyone knows, please write it in the chat box. We said before, implementation of the action plan for disaster management, number 1, and then implementation of the job codes, the job description for each of the staff, the task description for everyone. Okay, so here it will be in the form of 2 important items: disaster management action plan in hospital and job shorts for disaster management. According to the disaster management plan, who will start acting after the first calls that reported the incident in the hospital? Who will act? Who will be in charge? Who will direct all the staff after receiving that there is an external disaster and there are injured people who my hospital will receive? Who is in charge? If you know, please write it in the chat box. Who will be in charge? Hospital residents. Okay, hospital director and residents and medical resident medical officer and the nursing superintendent and the public relation officer in the form of what? What is their name? Their name is the commanding center, okay? Who will be in charge? The commanding center, okay? What is the recommended flow of patients in this case? The recommended flow of patients, as we said before, after triaging the patients, they will be directed according to the priority code to the corresponding service. Either they need emergency department or observation and stabilization or observation and ward admission, or are classified as deaths, okay? In case of crowds and troubles, who should deal with the proxy of the injured and why? Who should deal? Okay, thank you, doctor. Who should we deal with the proxy? Who should we deal with the crowdness and the relatives of the patient? Who should, do you think who should deal? Security, excellent. Yes, it is security. Because the relatives or the proxy of the patient may be interrupting the work of the healthcare provider. Okay. Let's move to case study. The last is case study number 4. It is also a short case study. On the 2nd of June 2022, an active shooter opened fire inside an Oklahoma hospital. 10 people have been wounded in the shooting, but no injuries were considered life-threatening. The gunman, described as 35 to 40 years old and armed with a rifle and a handgun, have died from a self-inflicted gunshot wound. What is the type of disaster presented in this case? If you know, please write it in the chat box. Is it an internal disaster or an external disaster? Yes, excellent, internal disaster. It is an internal disaster. Very good. Internal because the source of the disaster is inside the hospital. Who should be posting the information to the media or the news in such situation? Who do you think who should pass the information? If you know, please write it in the chat box. Who should pass the information to the media? Who do you think should pass the information to the media in this case, in case of internal disaster? The administration. Yes, okay, thank you, Dr. Dr. Musdalifa. Okay, thank you very much. Okay, it is the administration. Very good, thank you very much. It is the hospital management or the administration of the hospital. Excellent. What are the steps that should be taken in such type of disaster? As we have discussed before, there are 5 steps, starting by pressing the disaster alarm from the source, okay, and announcing the emergency code in this case, turning off the lift and evacuating the patients, and hospital security team should control the crowdness, okay, turning off the power supply if needed, and finally, when the situation is under control, announcing the code green. Okay, here we have finished our lecture. Thank you very much. I was very pleased to be with you today. I will leave you with Dr. Nesreen has joined, and I will leave you with Dr. Nesreen. Thank you very much. Okay, and goodbye. Dr. Nesreen, are you here?
Yes يا دكتور ولاء. انت ستوب شيرنج بس السلايد بتاعتك عشان اعرف
Okay.
اعمل شير من عندي.
Okay.
ميرسي ثانك يو.
Okay, good boys. Thank you.
Goodbye. Welcome. طيب, can you see my screen please? Yes. Welcome back. طيب, المفروض ان احنا هناخد ان شاء الله دلوقتي اللي هي البوست ديزاستر ريكفري فيز. We are waiting ان شاء الله كده نشد حيلنا ال next 2 hours. Post disaster phase is for relief, rehabilitation and reconstruction. For post disaster phase, we are doing a post disaster recovery, damage assessment, post disaster epidemiological surveillance, and post disaster public health intervention. في البوست disaster recovery ده المفروض shall be part of the hospital disaster management أو response plan. عشان نخلي post disaster recovery المفروض نمشي على 10 steps. The 10 steps هم الستep الأولاني نخلي member to assign a member of the staff to oversee the hospital recovery operation. Okay. Step 2, we want to determine essential criteria and the processes to deactivate the disaster response and recovery عشان نرجع للnormal operation. With step 3, undertake a post-disaster damage assessment. Step 4, we want to estimate the time and resources that shall be required to undertake complete repair replacement before a facility that is severely damaged can be reopened. يعني نشوف الدنيا what is severely damaged to repair before continuing our normal operation. In step 5, we should undertake a post-response hospital inventory assessment and consider repair or replacement of equipment as required. In step 6, we should submit a post-response report to the chief of the hospital. Debrief the staff immediately after the disaster response phase. خلاص, يبقى احنا بنعمل ريبورت للمانجر وكمان بنعمل debriefing للستاف When appropriately recognize the services provided by staff, volunteer, external personnel, and donor during disaster response. We are going to discuss what have been done by the staff and volunteer. Monitor the post-disaster health situation in the local community. And systemically and completely document the lesson learned, ودي is the most important part عشان نعمل لنفسنا evaluation for replanning. Damage assessment. We want to do early conduct of a damage assessment is essential to identify urgent need and to do relief priority for an affected population. المفروض ان احنا نشوف ايه الاحتياجات الurgent for the affected population. During this assessment, we are going to do the following. We are going to estimate the magnitude of the disaster, extent, number of affected persons, estimated duration, the impact على health, number of deaths or affected people, the integrity of health service delivery system, the healthcare needs of survivors, the disruption of service sectors, the power, water, sanitation, the extent of response to the disaster. يبقى احنا we are doing a damage assessment. بنشوف magnitude of the disaster، ايه تأثيرها على الهيلث سيرفيسز، ايه الاخبار، الهيلث كير نيدز بتاعت السرفايفر، ايه اللي احنا محتاجينه من باور ووتر وسانيتيشن. To gather a small amount of relevant information quickly، يعني الاستيميشن انها 2 to 4 days after a sudden impact disaster. وبيبقى فيه multidisciplinary team epidemiologist, statistician, engineer or health planner. بيستخدم طريقة الفيجوال inspection أو الobservation أو interview with key personnel and survey to assess the damage. they are waiting for في الريبورت إن يبقى فيه mortality indicators, morbidity indicators, number of damaged houses, homeless people, non-functioning hospital, status of the community, الwater والelectricity والgas والsewage disposal. Then we should do a post-disaster surveillance. Post-disaster surveillance زي ما قلنا ان معانا التيم فيه statistician و epidemiologist. The role of the disaster epidemiologist ايه بقى؟ Measure and describe the adverse health effects of the disaster and factors that contribute to those adverse events. يبقى ايه ال health effect اللي موجود والفاكتورز اللي ايه affecting them. We assess the need بتاعت ال population and matching the resources to those needs. We evaluate the health program بقى effectiveness and pre-plan for emergency. الابيديميولوجيست والسيرفيلانس في حد ذاتها الرول بتاعها to link data collection to inform decision making عشان take a proper decision based on data collected. طيب ايه type of data اللي collected for post disaster surveillance؟ زي ما قلنا في حاجات على mortality, morbidity, nutritional status, activities and vital sectors. For mortality هيبقى في حاجة اسمها monthly mortality rate, under 5 mortality rate, communicable diseases ده في morbidity, nutrition related diseases زي protein energy malnutrition, pellagra, الأنيميا. في nutritional status هنعمل screening للميد upper arm circumference, survey للweight for height. في activities اللي هتتعمل immunization, feeding center attendance, number of outpatient, inpatient admission, referral. في الفيتال سيكتورز هنشوف الاذر بقى requirement زي الووتر والسانيتيشن والكلوزنج والشلتر. في الريليف كامب نجمع بيانات على الريليف كامب عن التوتال بوبيليشن هناك، الات ريسك جروب، المورتاليتي، النيوتريشنال ستاتس از ويل، الافريج فاميلي سايز، الموربيديتي، الهيلث بروجرام اكتيفيتيز. كل دي داتا كولكشن زي ما بنقول ان الابيديميولوجيست بيلينك الداتا اللي كولكتد وبيوصلها للبوليسي ميكر تو تيك انفورمد ديسيجن. ايه الببليك هيلث انترفنشن اللي احنا we should expect في البوست ديزاستر فيز؟ في البوست ديزاستر public health intervention في 3 major area of focus. post disaster public health measures, strengthening surveillance و daily reporting. في البوست disaster public health intervention we have 3 focus. نعمل public health measures اللي هنقولها strengthening surveillance system و daily reporting. البوست ديزاستر public health measure ان احنا يبقى في safe water supply, food hygiene, proper sewage system, vector and rodent control, and public health education. Those are some of the public health intervention في post disaster phase. Strengthening the surveillance system should be in place as early as possible after any disaster عشان to send any early warning sign. Surveillance should focus على main health problem expected بعد emergency. The system for the surveillance should be simple, feasible, and adaptable as any surveillance system. والdaily reporting للsurveillance في diseases هيبقى في daily reporting إذا كان حصل acute diarrheal diseases, viral hepatitis, enteric fever, measles, chickenpox, fever of unknown origin, scrap typhus, bacillary dysentery, cholera, malaria, dengue, acute respiratory infection, leptospirosis, snake bites. طيب ندخل بقى على الكيس ستادي اللي فيها بنشوف how to learn from the experience. How to share the experience we learn from it. Learning from crisis helps system improvement. However, learning from major event is very challenging because each event is comparably rare and occurs in a distinct context. يعني كل disaster ليها context اللي هي بتحصل فيه والليسون المختلفة. فlet's start. This is a case study. Doing a retrospective analysis study that was conducted to describe the action taken by the organizational management of an emergency services due to COVID-19 pandemic. عملوا a retrospective analysis through document analysis. What they have done? They have found that due to increase in the demand during the epidemic, changes حصل في hospital. Changes were necessary في physical structure, the organization of professionals who work in the emergency sector, including remodeling of the physical structure and adaptation of the flow protocol due to new reality. How did they do this? أول حاجة, a work proposal was elaborated to evaluate the impact of the pandemic. The work proposal ده, within the Institute and Trigger Action, the proposal was developed at 2 stages. Stage 1, formation of what we call the crisis office. I would like to ask, what I'm afraid to ask, if you remember the management from the emergency preparedness guideline in the second lecture. The management should have, the hospital should have what we call a hospital emergency committee, which will assign what we call, can you complete the following, what we call, during an emergency, the hospital emergency committee assigned what we call an incident command group. Here in the case study, they formed what we call a crisis office to develop the incident action plan. They call it in the paper or in their experience a crisis office. The crisis office formed in the first stage of the increase in the number of cases being attended included a multidisciplinary team, okay, including several sectors اللي ليهم direct and indirect relation بالpatient care. The crisis office was formed by the general management of the unit, the administrative management, the pharmacy, diagnostic support, nursing, the intensive care, emergency, research center of the unit, multidisciplinary. The group had systematic meeting to create an action plan. The actions were evaluated and replanned through what we call online meeting. والissue which was not discussed during the online meeting استخدموا فيها message WhatsApp. The organization of the action plan within the model of crisis management defined action based on patient from their arrival in the unit until their discharge. يبقى كان في crisis office developed the action plan, والاكشن plan في details على patient, what we do to the patient from من أول ما يوصلوا لغاية discharge. What to do in the adequate triage, okay? The clinical management of the cases, notification, equipment and supply, logistic of operation, and the protective measures of the frontline workers. All details in the action plan. وبرضو were defined في الwork proposal emergency attention, clinical hospitalization, intensive care hospitalization, supply, logistics, diagnostic therapeutic support, communication with information, work protection, and the contingency plan. As regard the case management identifies and prioritizes the patient according to the severity of cases using the Manchester protocol. بس ال country experienced a collective and uncoordinated اللي هنا بقى ال challenges personal protective equipment regarding to purchasing the supply. Although the institution being studied is responsible for managing its own resources using the budget destined to it, many supplies were not delivered according to the date agreed upon. Okay, they agreed to purchase personal protective equipment, but many supplies didn't arrive and were not delivered. Well, purchasing sector had to deal with high prices and manage resources and for protection of the workers. Okay. In spite of the efforts of the government, the COVID-19 pandemic exposed the country to shortcomings in regard to institutional acquisition of supplies from the health system. يعني كان في problem في resources. The dispute involving many countries في public and private sector للsupply والventilator والsanitizer والpersonal protective equipment. يعني الchallenge دي may be يعني need to create new plans or centralization للpurchase of these products. The use of personal protective equipment in adequate condition and the availability of this equipment is essential for health workers in the context of COVID-19. يبقى personal protective equipment are essential, we know. Therefore, the health team received guidance or training or what we call about how they should rationalize the use of this equipment, saving them for the most critical moments. Because as we said before, there was a problem in purchasing those resources and they were not available. Considering the reduces of workforce and attempting to minimize the exposure by optimizing the time of assistance, it is relevant to mention they used what we call the lean methodology. The lean methodology is a tool originally used in the field of engineering that was adapted to be used in the field of health. It seeks to improve the management of services by rationalizing resources, spaces, supply, and guiding the workers about the best practices of care according to evidence. يبقى to rationalize the use of resources, they used what we call a lean methodology. In order to disseminate the information, the protocol of the institution, and considering there was a lot of uncertainties and the speed of the information, a Center for Patient Safety, based on the best scientific evidence available at that time, عملوا a creation أو initiative of technical notes, which became part of the document of the unit. This material gave support for the production of institutional documents presented in the short in the alphabetical order in order to present them effectively. They were also translated into illustrative cards distributed around the institution. This is for the clinical part. They developed technical note based على the most available scientific evidence. Okay. طيب. In regard to worker protection, during the pandemic, the problem faced daily by nursing workers who stand out related to work condition, high workload, low pay, inadequate work environment. They found that COVID-19 exposes not only to biological risk of contamination, but also to psychosocial, including stress, mental, physical exhaustion, depression, and burnout syndrome. Okay, تمام. Nursing Observatory National Council of Nursing registered لغاية 2021 47,664 cases of COVID-19 in nursing workers with 535 deaths وده كان في ريو دي جانيرو اللي هي ال third state in the country in number of reported cases and the second in number of deaths according to gross data. Therefore, this study proposes the re-evaluation of management and attention protocols for suspected or confirmed COVID in emergency service to guarantee nursing professionals safe and dignified work by promoting the prevention of physical and mental disorder in these professionals. As well as that surveillance is necessary. We said that in the recovery phase, we are caring about the mental status, about the surveillance, about collection of data, about reviewing lesson learned from the experience. In addition to the rigorous control of its dissemination and early identification of cases, in order to predict the necessary resources for emergency care. The control of the dissemination of the disease should be effectively strengthened in and out of health institutions. The same is true for measures to contain and mitigate the pandemic, including social distance. Those are اللي هي screenshot من what they have done. Okay? عملوا physical structure المانجمنت عملوا changes فيها. Changes this is a screenshot from there what they have done في البيبر دي في الريسيرش ده في البلد دي في country دي. Changes in the layout of the risk classification room, division of the attention wings في COVID free to attend emergency patients with no respiratory symptom. The entrance for workers was changed to the door to the side of the emergency entrance عشان to avoid passing through the reception. Organization of the areas where workers put on their vestibule equipment, حطوا water tank, liquid soap, alcohol, gel, personal protective equipment. They are documenting what they have done, changes in the physical structure. برضو الاريا بتاعت removing of the vest was reorganized. في برضو water tank و alcohol gel. Definition of places for first medical attention. Okay. With the recommended distancing between armchair equipped with material for immediate oxygen. Thank you so much. As regard for the human resource management, they train the multidisciplinary team about wearing and removing the personal protective equipment, training the nurses for risk classification so they can identify early sign of severity, revision of the administrative attribution of those who work on duty to guarantee that assistance is provided to critical patient, sizing the nursing team, ممكن transferring workers from less critical sector to increase the workforce for emergency, monitoring طبعا لو حصل absenteeism due to COVID-19 and daily observation of sign of emotional exhaustion على frontline workers. They were documenting what they have done in the human resources management, in the assistance management, in the physical structure management. What have we done as lesson learned from this case study? Can you answer me even in chat? Thank you for your nice comment. Thank you. Can someone add their perspective on this case? Document one lesson learned from them, two, perhaps three. I can give you 2 minutes. So this is state in Rio de Janeiro, problem of resources. They had a problem of resources, personal protective equipment. They have done something to deal with this problem. What they have done. They have problem with case management, what they have done in this case. Can you share with me your perspective, please, through chat, if you can? So my lesson learned in this case that there were, due to increase in the demand during epidemic, changes were implemented for physical structure and the organization of professionals. You have seen what they have done in the physical structure and the human resources. In the first phase, they have a work proposal that was developed in 2 stages. They developed what we call the crisis office, which was responsible for an action plan, and the crisis office included a multidisciplinary team. The action were evaluated and replanned for a weekly online meeting, okay, and through phone. The case management that I identify and prioritize patient due to severity of cases using Manchester Protocol. Supply which were not delivered in accordance with the date, they manage the resources as well as protection of workers. They help the team. They give them guidance or training about how they should rationalize the use of the personal protective equipment. There was a recommendation there may be a need to create new plan to centralize the purchase of products because the country had a lot of problem during provision of the supplies. So maybe we need to centralize things. In order to disseminate information, a Center of Patient Safety في technical note he based على best scientific evidence عمل creation ل technical notes and disseminate the notes to help the healthcare professional. Nurses were exposed to biological risk and to stress. We should take care of the mental and psychological stress that faces the healthcare workers, including nurses. So we had 10 steps in the post-disaster recovery. Post-disaster recovery is important that we do a disaster assessment. In the above case, we have done an assessment and we have done a report, we have done paper, scientific paper from it. Let's go for the second case study, and I hope it will be more easy and for you to answer the question. So let's concentrate. This study examines perception of the operational and organizational management. This is an older study, 2016, about a major outbreak of MERS, Middle East Respiratory Syndrome في السعودية. Perspective were sought from key تاخدوا في الstudy from key decision making clinical staff about the factor perceived to promote and inhibit the effective rapid control of outbreak. This was mainly a qualitative study. Okay. We want to ask the key decision making of the clinical staff in this study. They asked them about the operational and organizational management of this outbreak. The study focused on the major outbreak of MRSA, which occurred in a large teaching hospital in Saudi في June 2015. The outbreak resulted in 130 cases with 53% mortality rate. Okay. The outbreak directly or indirectly involved 9,000 healthcare workers. One-third of the infection cases were in healthcare workers. Half of these cases can fill emergency department staff with no deaths. يبقى half الكيسز كان تلت الكيسز كان في الهيلث workers وكان نص half الكيسز في ED staff with no deaths. Okay. When we discussed of them the high stress of the outbreak, all the participants, this was an old study, 2016, reported in MERS was an outbreak, was one of the most pressing and serious clinical significance to the organization. It was before the COVID. The perceived seriousness of the outbreak was reported to motivate staff to expend maximum effort to assist in its management. يعني their perspective, it was very serious outbreak, but the seriousness motivated the staff to expend maximum effort. This was their perspective. Okay. When they were asked about factors perceived to have contributed to wide occurrence of the outbreak, they said that there was at that time inadequate implementation of infection prevention control guideline, lack of primary care services, problem associated with patient flow, poor communication and teamwork, lack of national plan to allow hospitals across different sectors to share the burden of the growing population. يبقى لما تسألوا what are the causes in the outbreak that was spread, قالوا إن at that time it was in 2016 before the COVID pandemic, they said the clinical staff of this teaching hospital during this era said that there were inadequate implementation of the IPC guideline, lack of primary care services, problem with patient flow, problem with communication with teamwork, lack of national planning to referral maybe across hospitals. When they were asked about what factors they perceived to have contributed to the success of the control, they said they had a clear shared vision across staff, high frequency of meeting of decision makers involved in the outbreak, high level of accountability. يعني although they said they were inadequate IPC, communication, teamwork, primary care services, they saw that their factors for the success of the control, which were mainly shared vision, frequent meeting or communication, especially among the decision maker, high level of accountability. They had a centralized command and control center committee that was seen widely to facilitate with high accountability. They were very happy with the management of the outbreak. The factor that they saw inhibiting the outbreak control was mainly a poor staff orientation, and management ambiguity contributed to staff being isolated and unclear about decisions. Staff capacity to handle a challenging situation was further reduced because of the high anxiety, lack of appropriate staff counseling, mental health support. At that time, it was a problem, okay? Almost all frontline participants strongly and repeatedly expressed the need for counseling and mental health support for employees. So if you want to give me lesson learned from this case study, which was in 2015 in Marsa in one teaching hospital in Saudi, what are we going to retain? If you can share with me the chat box. Okay, preparation is important. Thank you. Vision is important. Accountability is important. Communication is important. Yes, thank you. Staff education, of course. mental support for the staff because they were complaining, they needed counseling. So the lesson learned, there was a lot of stress, but the staff were motivated. There was a problem في ال IPC infection control, في lack of primary care, في ال communication, but there were clear vision, accountability, command and control center committee command, frequent meeting, proper decision making. So it was an important. But factors related to staff, counseling, training, mental health support, we should take care on. Can you see my screen? These are a screenshot from those the lesson learned in their study. Can you see number 5 and 6? Number 5 and 6 are very important, which is healthcare workers, healthcare workers, mental and anxiety relief are important factor to increase resilience and cooperation within the workforce. Despite the immediate consequences of a healthcare crisis, it can represent a strong drive for change and institutional reform. I think those are very important lessons. So we should take care of the mental health of the staff, and we should learn from a healthcare crisis. Okay. 1 minute and I will share the next presentation. فاضل إن شاء الله one lecture إن شاء الله it will be easy. So we have to outline of the hospital emergency management policy brief, case study, and summary. Okay. We have a policy brief. What is a policy brief? If you know, in hospital emergency management policy brief, we are in the recovery phase. We want to learn from our experience. To learn from others, we can read their report, read their studies, research, or read their policy brief. What is a policy brief? A policy brief, we can write a policy brief after the study, because we need the research is unfinished unless the findings are interpreted, applied in practice, shared with others. But sometimes, as you see in the caricature in the the following: the policymaker or the decision making doesn't have time to read a lot of presentation, a lot of reports, a lot of paper. He needs it to be summarized, to summarize the finding, the recommendation in bullets, to read them and to be easy to interpret and to implement. So we see that policy briefs are a valuable tool for communicating the research findings. They help to bridge the divide between research studies and policies. They translate the knowledge into context-relevant messages for the target audience. We see the policy brief as a concise publication that focuses on a specific issue requiring policy attention. It presents a problem with its context, suggests clear policy recommendation with the required evidence behind this recommendation. So we have a problem, emergency problem, context, background, what we have done, our finding, and so we can build our recommendation. It is 2 to 4 pages long and written using a professional style that is easy to understand. The following is an example of a policy brief that recommends increases in human resources for mental health care, which is an important. When we write a policy brief to be presented in 2 to 4 pages, we write a title and summary in 150 to 200 words, and then an introduction, 150 to 200 words, that aim to capture the attention of the audience. The introduction contains an overview of the problem, background information, context, importance, and purpose. Then we write the methods, the results, and the conclusion. Okay. Then we read this case study. This case study is a policy brief of the U.S. Nursing Leadership Supports Practice Academic Partnership to assist the nursing workforce during COVID-19 crisis. They proposed an innovative approach to deal with the problem of human resource shortage. Let's see what they have done. I can give you 1 minute to read it, and then I will read it myself. I will read it. The policy brief is a collaborative effort of nursing leaders who propose and support academic practice partnership, okay, between healthcare facility and pre-licensed registered nursing and the practical vocational nursing program across the country. This is one potential model to consider. It is not mandated. Policy brief, it is not mandatory. We should not all do. It is rather an innovative approach to meeting academic workforce needs. The proposed model requires cautious evaluation at the local level with a clear understanding that the participation of student nurses and faculty is voluntary. يبقى we are going to use student nurses in the practical, but it is voluntary and must comply with any additional requirement mandated by the state emergency response provision or through existing occupational safety طبعا and health administration. يبقى voluntary, submitted to the emergency response provision, to occupational safety guideline. The safety for all frontline provider of services across multiple points of care must be safeguarded. We must guarantee their safety, okay, through appropriate infection control practices, okay. The context in the COVID-19, which was a virus affecting the entire world, to date thousands of people في US, طبعا دي كانت an old policy brief, have tested positive for the disease, and it is anticipated that many more will be affected in the near future, and they were affected يعني. After observing the pattern of the virus, the US anticipate an overburden of patients in the hospitals and possibly overwhelming the healthcare system. Significant demand is being placed on the entire nursing workforce, and this is anticipated to increase at an alarming rate. Simultaneously, نفس الوقت, at the same time, the pandemic has affected nursing students across the country. Clinical experiences with patients is an essential part of every nursing program curriculum and are mandated by the state boards of nursing for license. Many hospitals and healthcare facilities have determined that pre-licensed nursing students should not be in contact with patients. ده طبعا will affect their training and have discontinued student clinical experience in their facility. Without this valuable experience, all nursing students will have a deficit in their education and will be unable to meet their program requirement and will not be eligible for graduation at that time. So we have the double problem. What to do بقى? البروبوزال in the healthcare facilities and the nursing education program are encouraged to partner during the COVID-19 crisis. How? The pre-licensed students from diploma والassociate degree والbaccalaureate degree nursing program and the students from certificate nursing program could augment and support a nursing service في healthcare facilities. Okay, they can have them additional resources, additional human resources, as we have discussed previously in our slide. Nursing students would be employed by the facility on a full or part-time basis and would work in the role of a student nurse for compensation. خلاص? And in conjunction with the students nursing education program would receive academic credit toward meeting a clinical requirement. يعني he will have to provide an additional resources as well as he will get his academic credits. Double benefit, win-win. Okay. Nursing students would be required to be enrolled in a state board of nursing approved. خلاص؟ البنفيت لازم أي proposal, innovation أو innovative approach, I would encourage people to do the same or to implement. Although it is mandatory, it is voluntary, but I want my innovation or solution or my initiative to be widely implemented and to scale up. This opportunity not only provide much needed clinical education to assist in meeting program requirement, it is an unparalleled opportunity for nursing students to assist the nation in a time of crisis and learn the principle of population health and emergency management. يبقى they are going to provide extra resources, and at the same time they are learning the principle of population health. This academic practice model demonstrates that a disruption of the environment, such as COVID, maybe continuous innovation can occur and can be implemented. Recommendation. يبقى we have discussed the background اللي احنا فيه في البوليسي بريف. الباكجراوند we have a problem of the COVID-19, we have a problem of the nursing shortage, human resource shortage, we have a problem that the education is in the clinical setting is not continued, what to do. So we are going to ask students to attend and help, and at the same time they will gain the credit academic, and will be a win-win situation, and they will learn population health and help in the emergency. And this is totally voluntary. This initiative is totally voluntary. Recommendation: healthcare facilities and nursing program are encouraged to promulgate plans to take advantage of this opportunity and make every effort to reach out to eligible nursing students and inform them of the opportunity. Healthcare facilities and nursing program are encouraged to collaborate to identify ways to accomplish appropriate faculty supervision. If the academic want to do supervision of the nursing students employee initiative to achieve a final learning outcome, they are invited to do their supervision. For example, the healthcare facility could hire a nursing program faculty to oversee the nursing student employee. The nursing program faculty could hold a joint appointment by the college, university, school, and the healthcare facility, or the healthcare facilities employed preceptor could oversee the nursing student employee. So we can have a supervision for the academic part from the faculty. The nursing program leaders faculty are encouraged to work with the healthcare facility representative to align clinical skills and competencies with the nursing student employee work role or responsibility. This is an initiative for collaboration, partnership between the academia and the practice. Okay. Nursing student employee must have planned clinical practice experience that enables the students to attain new knowledge and demonstrate achievement of the final learning outcome of the nursing program. Nursing program should consult with their state board of nursing to ensure clinical requirement regulation would be met with this opportunity and experience. Nursing programs are responsible for informing nursing students of the responsibility associated with working in a healthcare facility at this time. Additionally, nursing programs are responsible for communicating with the students about their rights to be protected from infection and their option for completing the clinical practice guideline of the nursing program. Okay, clear enough this innovation? Okay, we have another policy brief about another issue is the stuff related to staff education in the emergency preparedness. Disaster preparedness knowledge and its relationship with triage decision-making among hospital and pre-hospital. First of all, the above policy brief, do you think can be widely implemented in similar emergency situation? Can answer using the chat box. Do you think? I will type in the question. Do you think that this what do you think? Do you think that this initiative can be implemented widely? This is my question. Let's see. collaboration between academia and practice to increase the resources, human resources during an epidemic. Thank you, Dr. Hosni. Let's try to put an attractive title instead of this one for the points brief. The title is Disaster Preparedness Knowledge and its Relationship with Triage Decision Making among Hospital and Pre-Hospital Emergency Nurses. Can you help me simplify this title to be more attractive for the points brief? Okay, please use the chat box, Dr. Musallam. Are you saying yes for simplifying or making the title more attractive, or for the implementation of the initiative of the academia and the practice partnership? Implementation? Okay. So anyone can help me to simplify the title, make it more attractive to suit a policy brief? Disaster preparedness knowledge and its relationship with triage decision making among hospital and pre-hospital emergency nurses. Can we make it more attractive? Can we try? The next 2 minutes, please. Can you help me? Anyone? Okay, I can say the nurses' preparedness knowledge and the effect or the impact of the nurses' preparedness knowledge on triage decision making. So let's see what are they saying in this brief. They are saying, as we know all, the disaster situation or event that overwhelm local capacity and requires application of foreign assistance, nationally or internationally. Healthcare workers working in various service sectors are one of the vital assets in any country. Okay? In the event of a disaster, emergency nurses, including hospital and pre-hospital emergency nurses, are the first group of healthcare providers to treat the injured and provide the necessary medical care. So their role are very important. Okay. The pre-hospital emergency nurses are the first responder in emergency, from disaster to minor injuries and illness. The role of the pre-hospital emergency nurses during disaster include responding to critical situation, detecting danger, reducing or eliminating injuries, managing an incident on the scene, managing and distributing medical equipment, and performing mass care, triage, and emergency treatment. On the other hand, hospital emergency nurses are among the first-line healthcare professionals in the emergency department that respond to disaster. They make up a large group of those receiving, assessing, and treating victims of disaster. So preparedness is an important step in the disaster risk management based on Sendai framework for disaster risk reduction. As we said in our first lecture, the framework in 2015 to 2030 make an emphasis on risk reduction and preparedness, include steps that are already taken to ensure effective response. The health system, as the most important organization, can prepare appropriate programs and strategies to reduce social and financial losses. In developed countries, health systems need to plan for disaster preparedness and skill development, and this plan must be up to date and all personnel must be aware of it. Preparedness of health system, especially pre-hospital and hospital system, is essential. Having preparedness for disaster and the proper response of health team can maintain stability in the community. Disaster preparedness knowledge is the ability to define a disastrous event, understand the incident command system, triage and assessment the role in a disaster event. Emergency nurses must be equipped with the knowledge needed to deal with a disaster because disaster preparedness knowledge can help maintain stability. All these are background on the importance of disaster preparedness knowledge. This was a study conducted to know the factors that affect a knowledge of disaster preparedness. Can you tell me from this slide what are the factors affecting this knowledge? At the global level, the existing literature shows the experience of disaster response and education and training in disaster as two factors that have the strongest and most consistent relationship with increasing the level of objective and mental preparedness. They said that education, experience, mental preparedness بتاع nurses, residence, work experience, years as an emergency nurses, age, level of education, place of work, all these are factors that affect the knowledge of the disaster preparedness. They said that triage decision making is one of the first clinical decisions when caring for a patient. The purpose of triage is to identify the severity of the injury and reduce the negative consequences. Decision making is the most sensitive level of triage, and emergency nurses' knowledge can be a more effective factor than their performance. Triage decisions are often made quickly, independently, and under time constraint, so they can have a serious impact on patient outcome and flow. Professional capability play an important part in the emergency nurses' decision. But considering the limited resources of nurses, as we have said, during disaster, it is important to understand the factors that affect their ability to cope with this disaster. The study was conducted to determine a level of disaster preparedness knowledge or relationship with triage decision-making among hospital and pre-hospital nurses. It was conducted in April 2021 on 472 nurses who were selected by convenient sample from 12 educational medical centers and 9 emergency medical services. To study what? To study the relation between their disaster preparedness and their triage decision making. The inclusion criteria of the study consisted of having at least an associate degree in nursing education, having a working of a minimum of 6 months in the emergency department, and being active during the data collection stage. Response rate بقى. How about the response rate? Out of the 821 nurses who met the inclusion criteria, 218 did not consent to participate in the study, 89 questionnaires were not returned, and 42 questionnaires were incomplete. Anyone can tell me what is the response rate for this study? Is it high or low? Is it a high or low response rate? High or low? Out of the 821, 218 didn't consent, 89 were not returned, 42 were incomplete. I think it's lower than 80%. I think it's lower. The data was collected using what we call the questionnaire, Emergency Preparedness Information Questionnaire, EPIC, and Triage Decision-Making Inventory. Emergency Preparedness Information Questionnaire, يعني if you want to repeat it or to use it, it is a 44 item instrument that was developed in 2004, and the reference is available. The questionnaire consisted of two parts. The first part about age, gender, level of education, workplace, marital status, shift type, training, triage training. And the second part, it is mainly about the disaster preparedness knowledge of nurses with 8 competency dimension of emergency preparedness. عندنا حاجات للincident command system 7 items, 6 items للtriage, 7 items للcommunication, الpsychological والvulnerable population 6 items, isolation والquarantine 5 items, epidemiology وclinical decision making 4 items. Access to critical resources 4, familiarity with biological agent 4 item, knowledge of and understanding of preparedness during critical situation 1 item. كله بيتقاس على 5 point Likert scale. اما triage decision making inventory دي 37 question على 4 sub scale. السب سكيل على cognitive abilities 14 item, experience 6 item, الايه كله على ليكرت سكيل بس الليكرت سكيل من 1 ل 6. What did they found بقى قبل ما نكمل السمري بتاعنا نبص على finding و recommendation to see the finding and recommendation before we make our summary. The emergency nurses did not have good disaster preparedness knowledge. The average total familiarity of nurses in the 8 subscales of disaster preparedness knowledge was low to moderate. The highest level of EPIC was related to the triage dimension. The lowest level of EPIC was related to biological agents dimension. Can you follow? That they were not prepared as regard disaster preparedness knowledge. 8 subscale. They achieved a low to moderate knowledge regarding disaster preparedness. والhighest knowledge بتاعتهم كان على triage dimension. Lowest level of EPIC was related to biological agent dimension. And this was conducted in 2021. 2021, after COVID pandemic and familiarity with a biological agent as an emergency or dimension, it was very low. Another finding, important finding in this study, that past experience of participating in disaster and age are predictor to disaster preparedness knowledge, which makes sense. If I am exposed previously or have experience or I'm older, I should be prepared or I should have more knowledge. Previous experience of participating in disaster, training, but about age, I thought it's about old age, but it's the young age which was associated with preparedness knowledge, not the old. So the age was negatively correlated. When I increase in age, my preparedness knowledge decrease in this study. What did they find? Again, they found that disaster training preparedness is a predictor of disaster preparedness knowledge. Okay, training is very important determinant of course of knowledge. They found also that there was a strong relation between triage decision making, and disaster preparedness knowledge. Of course, this was the hypothesis from the beginning, and they proved the hypothesis doing the results of the multiple linear regression that showed a significant and positive relationship between the dimension of triage decision making and disaster preparedness knowledge. Okay, so their main finding that familiarity with disaster preparedness was low to moderate, lowest in the biological agent, okay, highest in the triage. There was a relation between the age, the young age, the training, the experience, and the knowledge. There was a relation, the training was a predictor of the knowledge, and relation between knowledge and triage. What will be the recommendation based on those findings? Provide appropriate disaster preparedness information training to emergency nurses to increase their level of preparation. Of course, offer training, please. 2 specific methods are suggested to address this issue, including offering nurses routine disaster-related training that keeps them working as volunteers in various disaster conditions, and providing effective disaster-related information training and provide information using a seminar, practice, flyers, and other sources. Another recommendation, please encourage the role of the hospital and administrator and in professional organization to provide disaster preparedness training program to emergency nurses. Please, they should consider their age and experience so that they gain more knowledge in this regard, okay? Any questions till now before doing summary of our lecture today? For summarizing our lecture today? Okay. So today we discussed that there was 3 important phases in hospital emergency disaster management: pre-disaster phase, disaster phase, and post-disaster phase. Can anyone tell me one important thing to do during a post-disaster phase? Anyone can write down one thing, one step to be conducted during post-disaster phase? Okay, this is very good, Dr. Azim, but this is very good for during the pre-disaster. Be prepared, yes, for the worst, but what about the recovery phase? The post-disaster, what about it? It's very important in the post-disaster. It is, I think it is as important as preparatory, because as we are preparing maybe for something. I will share it with you. Yes, post-disaster phase. Okay. Give me 1 minute. Ten steps are very important in the post-disaster recovery. 10 steps, very important. 10 steps. Yes, excellent. Yes, excellent. We want a member of the staff to oversee the hospital recovery operation, to conduct a design damage assessment, estimated time or resources, inventory, surveillance. Do you remember that we have discussed before in the lecture? Yes, we want to learn from experience. Okay. I will, of course, we will share the material, inshallah. Okay. Hospitals have a primary responsibility of saving life. They provide 24/7 emergency care services. And hence, when a disaster strikes, the society falls back upon the hospital to provide immediate aid in the form of emergency medical care. So the hospital should be prepared. And we discussed in our second lecture, okay, in our second lecture that we should be prepared. And to prepare ourselves for a disaster in a hospital, we need to discuss certain categories. What were the categories that we discussed? The management. Do you remember the management category? The human resources, the pharmacy services, the laboratory services, the logistics, the patient management, essential continuing of essential services, support services. What else? Surge capacity. All these items were discussed to be prepared, okay? When a hospital has to provide care to a large number of patients in a limited time, which is beyond its normal capacity, this constitutes a disaster for the said hospital. Therefore, disaster for a hospital is a temporary lack of resources due to sudden influx of unexpected patient load. So the same event may have a disaster potential for a smaller hospital and not a bigger hospital. Okay, this is a summary of what we have said. Disaster can overwhelm the hospital resources, staff, spaces, and supply. Lack of any concrete plan to fall back upon leads to situations where there are many resources of command, many leaders, and no joint effort to solve the problem. Excellent, Dr. Azam. Therefore, all hospital emergency plans must have the primary feature of defining the command structure. As we have said, incident command group. The incident command group will organize an incident action plan based on the hospital emergency plan. We have discussed the type of hospital disaster. External disaster sources are outside the hospital, like accident, earthquake, flood, and internal disaster, the source is inside the hospital. And this is example of hospital external disaster. And we have discussed the Sendai framework for disaster risk reduction. The Sendai framework for disaster risk reduction from 2015 to 2030, which was adopted in 2015 in June. We have global target in the Sendai framework. Can you help me remember one global target? How many global targets in the Sendai framework have we discussed in earlier? Can you remember one target? Can you even predict one target for a framework for disaster reduction? Aim, our target, what to do? Why are we doing framework, global framework, regional framework for disaster risk reduction? We want something, we want to achieve something. Can you tell me one indicator, one target for doing a framework for risk reduction? So easy. We are going to do a disaster risk reduction. We want what? Yes, we want to reduce. To reduce what? Substantially reduce what? We want to decrease what? In a disaster, we want to reduce what? عايزين نقلل ايه? Yes, excellent. Excellent. We want to reduce number of deaths. Excellent. What else? Yes, we want to preserve the human life, to reduce deaths. Excellent, Dr. Azam, Dr. Ala. Excellent. We want to reduce deaths. We want to reduce what? Excellent, Dr. Osita. We want to reduce deaths and injured people. And in the disaster, there are deaths and injury. We want to reduce both of them. Okay? We want to reduce what else? Can you think about what a disaster can cause in a community? And just assume that you are responsible for developing a Sendai framework, and I want you to decide on our global target or our target or an indicator. Excellent, Dr. Nadia. Yes, mortality. We want to reduce the mortality and morbidity. Yes, we want to reduce the psychological effects. Excellent. يعني دكتور I didn't have your name. Psychological effect is a very excellent proposition, but it was not endorsed in the Sendai framework. I think it was number of deaths and number of injuries. They didn't mention the mental problem clearly as an indicator. Yes, morbidity. They want to decrease spread of infectious diseases. Excellent. They think about the damage to infrastructure as well. The economic losses. Can you remember this? We want to decrease the economic losses. Yes, financial. Excellent. We want to decrease the economic losses, the financial effect. Infrastructure, damage to infrastructure, damage to essential services, damage to hospitals. Okay. Very good. So the goal of the Sendai framework is to prevent new and reduce existing disaster risks. Thank you for sharing your perspective. Yes, it's very good. We want to decrease this. Yes, please. Yani, please, if you are invited to share in a framework for disaster risk reduction, sure, definitely you want to decrease deaths, you want to decrease the number of affected people, the number of morbidity, you want to preserve life, you want to decrease the financial losses, you want to decrease the infrastructure damage, you want to decrease the basic health services. All these are important factors that you want to do. Okay, this will be done through the implementation of integrated economic, structural, legal, social, health, cultural, educational, environmental, technological, political, institutional measures that prevent and reduce hazards. What is different in the Sendai framework? It is related to wide scope of reducing risk, including biological risk, people-centered, and with a special focus on health. Can you remember this slide from our second lecture? A main feature of the Sendai framework is the shifting the focus from managing disaster to managing risk. It is a wide scope, including the biological hazards, people-centered with a strong focus on health. So what is a major incident management? In health services term, an incident where the location, number, severity, or type of life casualties requires extraordinary resources. Can you tell me how to meet those extraordinary resources, what to do to meet those extraordinary resources during the planning stage or the preparatory stage before the emergency? Because as we have said and as we discussed before earlier, that every disaster is special in its context and in its response. So I'm not going to discuss case by case. I'm going to discuss how to prepare yourself for a extraordinary resource requirement. How are you going to deal with this? What are you going to do? I have discussed this part also in the second lecture, and I don't think that you remember, but you can think, you can predict what to do to be prepared for extraordinary resources. How are you going to get them? Root cause analysis, okay. How are you going to, and I have said this during the human resources, laboratory, pharmacies, during their preparatory phase, what to do to overcome the expected or the predicted increase in the supply, in the demand of the supply. Okay, someone says yes, root cause, not accept cold cases, excellent. What else? What else? I have suggested one solution to be done. High quality stuff, okay. But if there is a shortage in the human resources stuff, for example, what can I do? And I have discussed this with you all of and in my 2 to 3 lectures, I have discussed this in form of WHO guideline, in form of case studies. I have proposed a lot to overcome the shortage in the stuff. Can you remember any? Can you share with me any? What to do to overcome the shortage? Train you, excellent, excellent recommendation. Take volunteers, excellent, Dr. Hussein, excellent, and train them. You can use your both answers. Thank you so much. Take volunteers, or take from where? Doing what we called, do you remember the memorandum of understanding between hospital, between with the Ministry of Health, with the private sector, with the universities? Additional hour for staff. Are you not afraid of for their exhaustion, mental, so psychological? Okay, fund, excellent, Dr. Hussein. Excellent, community, excellent. Retired staff, can we use our retired staff to help us during the crisis? Do you accept use the retired staff? Do you accept to get the help of the retired staff during crisis? Do you accept? Do you accept the students? So if you want to summarize the extra, the additional resources, maybe volunteers, as you said, retired, universities, what else? What else? Do you accept all these as sources of resources to overcome the shortage in the staff? Maybe you don't accept, or someone said the only qualified, but with shortage and they are tired and longing, working for long tired hours. What to do? And we need extra. And what to do, doctor? A lot of initiatives, they use volunteer, refer patient. Okay, no problem. دكتور علا ماشي. To other facility. Okay, ماشي. Okay. Minimum qualification. Excellent. Thank you, doctor. So the phases of a major incidence, as we discussed a lot: preparation, response, and recovery. In the preparation phase, we have a planning, an ambulance operational plan for each hospital. We have equipment and training. We have discussed this a lot. Okay, no problem. Accelerate graduate. Excellent. You have a lot of excellent ideas. Thank you for sharing. In the structured response, command, safety, communication, assessment, triage, treatment, and transport. Which one of these are the easiest? Accelerate ingredients, يعني they were instead of 6 years in faculty of medicine, they may be 5 years. This was discussed and was not implemented. Instead of 5 years, make it 4 to accelerate graduate. Okay. So which is the easiest and which is the most difficult? The command part, the safety, the communication, the triage, the treatment, the transport. طيب, let's discuss if we want to summarize برضو our new information that we gained during this lecture, regarding new response technique or transportation. What we have you have discussed what we called mobile hospitals. Do you remember mobile hospitals? The types of mobile hospitals? Types of mobile hospitals? Yes, excellent. Using tent, terrestrial, shelter, flying. طيب, do you remember the limitation for the uses of the mobile hospital? Do you accept a mobile hospital? Are they effective? Yes, their limitation. Was there any limitation to use a mobile hospital? Any special recommendation you want to share about mobile hospital? Any future planning? Any best practices? Okay. Do you recommend the mobile hospital? All of you are saying yes. Is there any limitation for mobile hospital? Can you mention one limitation? Hygiene, okay. Can you mention another? Network, okay. Lack of equipment, excellent. Excellent. Thank you, Dr. Hussein. Thank you. Did you mention the difficulty of the road and transportation? I think we have discussed that one mobile hospital took around 53 hours to reach the site. Okay, urgent equipment. What's the future? What to do to improve their ability, the ability of the mobile hospital? What to do? Special recommendation to improve mobile hospital. Do you have any special recommendation? Must be for only for easy case. Okay. Okay, Dr. Ahmed. Okay. Sometimes we need them. يعني fire in a remote place. We need the flying hospital to evacuate the injured people. Do you have a special recommendation for the future of mobile hospital? I think we discussed to have a unified standard for them. Use what we call the future research on artificial intelligence to better use them. Try to use the telemedicine. We've discussed some benefit of the telemedicine in those situations. Do you agree that telemedicine is beneficial in those situations? Is telemedicine beneficial? Beneficial in emergency situation? Excellent. Yes, for consultation, totally agree. Totally agree, Dr. Hussein. Totally agree with you. Not in emergency, Dr. Talal? Even for consultation, Dr. Togan Al-Zubi. Mobile hospital uses for urgent condition. Yes, excellent. Yes, for consultation. Yes, Dr. Talal, you are with me. Okay. Yes, connected to remote expert advice. Excellent, Dr. Azim. Excellent. So telemedicine may be beneficial in those cases. Okay. Safety is not always easy to achieve. Communication. Do you know that we should have a risk communication strategy? Assessment to estimate the number and severity of injury. Conducted triage. Do the most for the most. Right patient at the right place in the right time. And recovery. We should learn from the future. We should report what have been done. Do assessment, surveillance. Do you remember what's surveillance and the role of surveillance? Can you share with me your thoughts about surveillance? Surveillance, what is it? What is it, surveillance? Mainly for what? What are the type of data that we collect? For what? Is it important? When to do it? In which phase did we discuss the surveillance? Any thoughts about surveillance? Yes, excellent, Dr. Hussein. Post-disaster, when I'm doing surveillance, I'm collecting the data to inform the decision making. I'm not taking an action. I'm just collecting the data and presenting them to help them taking informed decision. I'm collecting data on mortality, morbidity, on nutritional status, on the community, on the health services. Okay. Those are the components that was shared with you in the second lecture. The hospital emergency preparedness component, the management, the communication, the human resources, the logistics, the hospital pharmacy, the hospital laboratory, the essential support services, the continuity of essential health services, psychological and social support, patient management, and surge capacity. What to do if we don't have a protocol for patient management? What do you suggest to do? What is your recommendation for patient management in a new or unknown epidemic? An unknown epidemic. What to do? What will be your recommendation for patient management in an unknown epidemic? What will be your recommendation for patient management? Okay, triage, okay. Okay, updates, okay. Do you remember the case of Rio de Janeiro? They said that patient safety center in the hospital tried to collect the available evidence, the best evidence available scientific, and they used it to design what we call the technical notes with illustrative cards to help the doctors to manage the cases. What were the essential support services that we should think about it in the hospital that we discussed? What was the essential support service that we discussed and that should be continued even during the emergency because it's very important? What were the support services that we discussed earlier? Such as what support services? Very important to think about them and how are we going to maintain and to continue during an emergency. Okay, this is the health services. PHC, I think you are talking about primary health care service, education and policies. I think we discussed water, food, safety. I think we discussed as well burying dead bodies. We talk about patient. Okay, patient. Yes, we talk about patient. Okay, yes, we talk about patient. Yes, of course. I think that we are going to check material. So for now, if you are going to give me 3 important take-home messages that you remember from the disaster management, what are you going to tell me? What are you going, what do you want to share with me, please? And please share your thoughts. It's very important. Dr. Ahmed, pre, during, post, excellent. Yes, preparedness, response, and post-recovery. Can you give me, Dr. Ahmed, a word for each stage? Prepare, train, and teamwork. Yes, Dr. Azim, you very teamwork is very important, and I appreciate sharing the teamwork. Can you share with me 3 important word important in each phase or in each stage, pre, during, post? Any important take home messages that you remember from all these lectures? because what you remember is the most important or the most clear part in our lecture. And I appreciate to understand what was very clear and what was not. Hospitals and resources. Excellent, excellent. Plan, prepare, implementation. Don't you want to add evaluation as well? Plan, prepare, implementation. Don't you want to add evaluation or in the recovery phase? Train personnel with emergency procedure. Excellent, Dr. Talal. Yes, yes, please, please train your staff on emergency preparedness. Help them understand that they are guidelines. They should think proactively. They should be able to prepare themselves, to prepare the hospital, to share knowledge. Yes, excellent. Please train them. Please train them. Please.